এ টুপাই, টুপাই, প্রফেসর লাগলে তোমার কানেক্ট লাগিয়ে নেবে, কানেক্ট লাগিয়ে নেবে। স্পিকার নাই।
ఈ గ్లాస్
Hello. Yeah, tell me, ma. Tell me. ಎಲ್ಲಿ ಕಾಪಿ ಮಾಡಿದ್ದಾರೆ Teacher, what? Okay. Don't keep on switching all these things. ಸಡನ್ ಆಗಿ ಜೂಮ್ ಬೇಕು ಸಡನ್ ಆಗಿ
ಯಾವ್ದಕ್ಕೆ?
ಇಡ್ಬೇಕು ಅಂದ್ರೆ ತುಂಬಾ ಕಷ್ಟ
ಇದಕ್ಕಾ?
ಆಗುತ್ತೆ.
ಪೆನ್ ಡ್ರೈವ್ ಹಾಕಿದ್ಯಾ ಇವ್ರೆ ಪೆನ್ Kemudian, Okay. Really okay. 10 people are there online.
Oh, 10 people.
Sir.
Okay.
That is what I told, sir.
Oh, right. You know,
All are virtual, sir. That's what I told you.
Yeah, if you just put the message in, we are about to start.
Fine.
Okay, sir. I'll do it.
So
I'll
we
do
will
right
start
away.
from here. किसका है? सर,
मेरा first
ये आपका है ना? इको
यूज बोल के हाँ वही सर
Just put the message.
We are going.
आपके वीडियोस हैं?
We're about to start.
वीडियो नहीं
Photos. Login.
बस आपका ये है, इसको यहाँ पे थोड़ा वो करना पड़ेगा।
सर इसको यहाँ पे
नहीं रहने देते हैं, अभी कुछ भी हिलाते नहीं हैं। ये इससे ऑपरेट होगा ना सब? एवरीथिंग इट इज वायरलेस। 100 मीटर रेंज है इसका।
इसे
दिस इज पॉइंटर, दिस इज फॉरवर्ड, दिस इज बैकवर्ड। नहीं नहीं, ये वायरलेस है। It is not this thing. It is in the system. If you go there and do something, it will come on the screen. So it is not laser. लगा दे यार मेरे भाई। ऑन कर दे मेरे को। ओके फाइन, जस्ट अ सेकंड। ये लाइट्स बंद कर दो यार।
Lights on.
Stop the lights. Ananya, you're Ananya. Stop the lights, yeah.
सर वो ये पहले रख दीजिए सर
Mic.
ये पहले
Mic
रखे
है,
I just skip my I don't want to put this as a first slide
Mic.
Only mic.
Sir.
only my
Gautam, you be there. What happened?
Good morning.
I gave
Good
them my
morning to all. First of all, I would like to thank the organizing team, Central NFO organizing team, for giving us the opportunity to organize this advanced eco workshop organized by Andhra Pradesh. And
Dr. Naveed.
well, we have faculty, excellent faculties today. Starting from Dr. Momi sir, he's from Surat. He's a senior consultant neonatologist. He's got a vast experience in the field of neonatology, and he's been teaching and training people in ultrasound and echo. For so many years, he's a very experienced person. And then we have other faculty as well. We have Dr. Vikram Kudumala. He's a pediatric cardiologist from Andhra Pradesh, Vijayawada. He's got nearly 20 years experience in the field of pediatric cardiology. He worked in the UK for so many years. Worked there for about 17 years. He worked in all teaching hospitals, including Glenfield Hospital, Leicester, and in teaching hospitals in Manchester. So he has got a vast experience in pediatric cardiology. He's got a CCT in pediatric cardiology from the UK, and he's been with us with other hospitals for the past 4 years. And we did so many pediatric cardiac surgeries. We did more than 2,000 pediatric cardiac surgeries in the last 4 years or so. And then we have another faculty member, Dr. Naveed. He's a consultant neonatologist from Kim's Hospital, Kurnool. He worked in UK for so many years. He worked in big hospitals, teaching hospitals in UK, and he's got his MRCPC and also fellowship and neonatology. So welcome, Dr. Naveed. And we have other faculty members, Dr. Bhuja. Dr. Bhuja, she's a consultant neonatologist from Vijayawada. She's got more than 10 years experience in the field of neonatology, and and she did so many workshops, and she's well versed with all advanced echo teaching and training skills. Welcome, Dr. Pooja. And we have Dr. Revan, he's specialist from he's from AP and MD from JITMA, Pondicherry, and after that he's operation activities. Okay, and he's very good at advanced echo, mainly functional echoes, and in identifying the shock. We do have so many faculty members, and they're all very experienced, and I'm sure you have some academic piece today. So I think without wasting much time, so we'll start with the initial first presentation by Dr. And sorry to delay, there are some issues from the organization patterns, and there are about 10 people attending virtually. So we have a minute. Thank you. That's all.
First of all, I'd like to thank the secretary for inviting me to be part of this workshop. And I thank Dr. Ramarosa for giving me my introduction. My talk is about basic echo waves, meaning like a basic echo workshop, but quickly running to the use because these are not workshop and I was saying and I have been before coming to the workshop. We'll revise through the various ways. So as we all know, the heart is not straight like the brain's orientation. So the heart is over the capital waves like it is. The heart is angle, oblique angle. So it's angled like this, and position how yeah.
হ্যাঁ ঠিক আছে, এই তো শিম যদি আর লাগে ও বেলা কি বলেছি, শিম আর বিনস, আর এবেলা হচ্ছে ফুলকপি আর ঠিক আছে।
ওই মাছ কি একসঙ্গে ওই যে সব নিয়ে দুটো আলাদা করবো নাকি
ভালো লাগছিল খেতে, এবারে ওই গরমে একদমই খেতে চায় না, তাও বানাবে।
কি এরকমই?
হ্যাঁ, ঝালটা আর বেলা জিজ্ঞেস করুন যে ওটা খাবে কি খাবে না। হ্যাঁ কি
ফোন করছে?
না না, ফোন না, আমার প্রোগ্রাম আছে বলে আমি বাড়িতে আছি, পৌঁছেই না। না না, এইটা খাবারটা নিয়ে জিজ্ঞাসা করবেন যে ওরা খাবে কিনা, যদি না ফোন করে দেওয়া হবে।
তাহলে পুরো রাখলাম, আমি তো সিম্পল নিলাম।
হ্যাঁ, সে নিয়ে নিন, সেই জন্যই তো কি না, আমি একটা প্রোগ্রামের জন্য বাড়ি থাকলে এইসব টাকা ঠিক করতে পারি। সাপ কেন? কত খাবে তো, কালকের ওই মটর ফটর একটু একটু আছে তো, মূলো ভাতে আর মটর নিতে পারি, কাজেই
Yeah.
Okay. Exactly. This is a turbulent flow, and we need two types of droplets, right? Pulsar droplets and continuous flow droplets. Pulsar droplet is used when we are measuring low velocity flows, and you can accurately measure the velocity of a particular depth. So it gives an accurate measurement of the velocity as well as the exact depth where that velocity, where you're measuring the velocity. Continuous flow droplets are usually used for high flow velocities where the velocity of the blood flow is more than 2 meters per second, you can accurately measure the velocity of the flow with less sensitivity and depth recognition. So, along with whether is the maximum velocity, it uses that exact location velocity.
ఒకసారి తన మెసేజ్
So we need to use it for high flow velocities like captors, and when you're doing PPHM with the TRJ, so you use the continuous flow rockets. Now we do a report to establish whether the heart is structurally normal, how the function of the heart is, like doing functional assessment, and then we have other presentations as well about these things like PDA assessment and PPHM assessment and myocardial contractility, etc. These are the ones which we use now in a day-to-day practice. So always use segmental approach so that we don't miss out on anything. First thing is you should establish the situs. Yeah. So starting from the subcostal view, we try to establish how the situs is, the situs inverse to the situs solidus. Then you measure, then you go along this line, like measuring veno atrial connection. So IVC and SUC are opening into the atria. The atria are opening into the respective ventricles to rule out any isomerisms. And then ventricles assess their chambers, how they are, the large, normal size, the abnormality like hypoplastic left heart, hypoplastic right heart, things like that. So assess the chambers, and then you assess if the chambers are opening into their proper atrial arterial connections. So LVOT and ROT measurements, and whether the arteries are crossing over, the major arteries are crossing over. So that can be done with our subcostal and apical views. Once that is done, we are left with ruling out duct and what are the hemodynamic significance, and rule out any coarctation with the suprasternal views, and whether the pulmonary veins are draining to atria. And then in the end, you can do the functional assessment. Most of the times we eyeball and decide how, with experience, we get that. So we try to check whether the cardiac output is good. But we have proper assessment as well, which we'll be discussing in the later presentations. So always normal anatomy should never be assumed. It should be proven. So we should not assume that the chambers are opening into their respective arteries and things like that. So we have to prove that by doing the approach. So next we'll go on to the views. So these are the views, as you know. Subcostal view is the first view where we establish the situs, and then apical view. Parasternal views are two views, the long axis, short axis views, and then we have the high parasternal view or the ductal view, and then the suprasternal view. So we'll go on to the subcostal view. Next slide. So the first thing, like I said, was to establish the situs. So when you are holding a rope, so first you have a pointer on top on the rope. So just put it in a 12 o'clock position. So straight down, yeah, straight down, and you can see. Just next slide, please. I'm sorry. So we can see that's the spine, and that's the aorta, and that's the IVC. So aorta is to the left of the spine. If you take this diagonal line, this is aorta to the left, this is pulsating. And then on the right, you will see the IVC, and this is all the liver. That view should come first before we start going further. Because the situs inversus, everything gets mirror image, right? So we have to make sure that it is situs solidus. And then you assess your IVC, the collapsibility of the IVC. So once you do in the 12 o'clock position, then just tilt to the left, to the right, and then to the left. So to the right, you assess your IVC, how it is dilated and collapsing or not. There's one baby's volume depleted, things like that. You assess your IVC. Then if you tilt to the left, you will see your aorta. So that is you checking your IVC. That's the IVC. And so if you turn towards the left, you will see your aorta. In the IOTA, you can see your SMA and celiac artery. That is the UAC here. You can even do the Doppler there to measure if there is any significant effect on the PDA. And then you can do the measurements. So in the bottom line, you can see the Dopplers. The left one is a normal Doppler. The right one is where there is absent flow in the diastole. Absent flow in the diastole here. And then you have a reversal here. So absolutely significant. So things like that can be assessed. If you're not able to get proper access of the iota, descending iota, you can even do the celiac or SMS. So here the blood will appear red in color because it's approaching the pointer. The pointer is on the top. These are your arteries. It will appear red. But in the descending iota, you normally see a blue dots. So after doing those three things, then you assess the atria. So after doing your these positions, 12 o'clock positions, you go on to the 5 o'clock position. Pointing towards the down. So 5 o'clock position, and then you look up. You will see the atrial chambers. Right? The heart is oriented in an angle this way. So the posterior are the atria. So ventricles are slightly anterior. So when you put the pointer in 5 o'clock position and look down, you will see the atria first. Then you start tilting forward. Yeah. Then you see your ventricles. Then you tilt more forward. You will see the aorta. More forward, you will see the right ventricular outflow tract. Yeah. So you just have to tilt your probe upwards. Yeah. To see all the chambers. And when you are seeing the atria, you will see that the SVC is opening into the atria. So that you establish that the IVC. You can assess the pulmonary veins briefly, and then assess your ventricles, and then arterial crossover, like I mentioned. Here you are looking at the two atria, left atrium, right atrium, and this is the PFO. You can measure the PFO, you can measure the Dopplers. The PFO flow should always be red, which means the blood is flowing from the left atrium to the right atrium. When in pulmonary hypertension, you might see a bidirectional flow, but if you are seeing the totally blue flow there, that you have to think about PAPVCs. It's very unlikely that you will see a totally full blue jet if it is not PAPVC. Another view of that. Right. So once the subcostal views are over, then subcostally, like I said, you assess the atria first, then you can assess the two ventricles by tilting forward. In the ventricle, you can assess if there is any ventricular septal defect, how the chambers are. Then you tilt forward, you see your iota going from the left ventricle, so LVOT. See if the velocities are okay, the opening is okay. This is your right ventricular outflow tract. Yeah, and the arterial crossover is also can be checked. Your assessment of the left atrium, you can even check for pulmonary veins. So most of the cardiac, major cardiac anomalies, except your check with subcostal views. That's the gastric coronary we are doing here in the in the fourth chamber, then we go on to the apical view. Once you finish subcostal, you go on to the apical view.
Mic ఉంది కదా.
So, in the epical, we can assess the four chambers, then check for the offsetting of the AV walls. Like I mentioned initially, the tricuspid wall is more apical. It is attached to the intraventricular septum. You assess, you decide the tricuspid wall, that is the right ventricle. Yeah, the AV wall goes to the ventricle and not to the atrium. So decide whichever is the tricuspid wall, and that is usually your right ventricle. And there are features how you differentiate right and left ventricle, like left ventricle is capillary muscles, less trabeculated, right ventricle is more trabeculated, important for that. And then the portion of the MR and TR, yes. And then the intraventricular septum. Once you tilt a bit forward, the picture of where you see the aorta coming into here, and this is a motif followed by RVO. That's the portion of you, with all the four ventricles, and you can see that the tricuspid wall is more apical. That's the intraventricular septum showing your VSD. So we can assess the portion by abnormalities. PGA and PDA and its effects, like whether it is dilatation and all things like that. So we'll go on to the next view, the parasonal long axis view, where you put the probe in the 11 o'clock position. Yeah. So pointing this way, because the heart orientation is this angle. So if you're cutting it, putting the probe in this angle, you'll get the long axis of the heart. This is a text taken from another textbook. So that's the long axis. So if you're cutting the heart like this, that's the long axis of the heart, and usually presented upside down. So the atria are towards the right of the image, while the ventricles are to the towards the left. The parasol long axis view, like I said, the 11 o'clock position of pointer, and in the upper 2/3 and lower 1/3 of the sternum. Once you tilt your probe downwards, you will see the entry of the right ventricle, so inflow of the right ventricle. When you tilt upwards, you will see the outflow of the right ventricle. So those two tilts you have to do when you are doing this. So lower tilt and upper tilt. So where you assess the tricuspid regurgitation, or you can assess the main convolution. And any periventricular VLCs can be picked up in this. And then you can do the M mode, where you can assess your PDA and the effects of the hemodynamic significance of the PDA. We will discuss the next presentations. And you can also assess the practice. So this is a view. So interventricular septum, the right ventricle, the left ventricle, and the aorta opening there. So these are the mitral walls, and this is the aortic walls. So here you can pick up any perimeter VLCs. For M mode, for LAO ratio, you draw the line here, and you can do the M mode to assess your LA ratios. Then we move on axis. Where you tilt your probe position from this 11 o'clock position to this position, because the heart short axis is in this angle. So again, I'm taking the picture from one of the books. So you get the multiple short axis cuts, and then you get pictures like this. So that's the aorta in the center, and the whole heart wraps around the aorta. So these are the aortic wall leaflets, which you see as the bend sign or bend sign, 3 leaflets of the aorta. And then RUOT. Right atrium and left atrium, the interatrial septum. And then you can see the RUOT opening into the LPA and the right pulmonary arteries. So as you do the cuts, you can see coronaries there. Here you can see the coronaries opening. If you go further down, you can see the mitral wall, fishmouth shaped mitral wall. And further down, you can just see the capillary muscles of the left ventricle. Yeah, you can assess the intraventricular septum and things like that, the short axis cuts as well. That's the image with the aorta in the middle and the heart wraps around it. You can't see the right atrium in these views. Yeah, you can see the rest of the three chambers. This is the further down where you can see the papillary muscles, like I showed in the images. These are the two papillary muscles that and the ventricular septum moving into the right ventricle. With the pulmonary hypertension, you can see flattening of this interventricular septum. Yeah, so they should be curved into the left ventricle, right ventricle. Then you go on to the suprasternal view, which is the 12 o'clock position. So this is the assessment of the aorta. So you can see the aorta with its three branches and the right pulmonary artery here. So aorta wraps around the right pulmonary artery. In aorta and the center. Then you can put the Doppler and measure the velocities, and if there is any doubt about coagulation of the suprasternal. Then high parasternal view, which is one space, second to third intercostal space on the left side. The point is towards the 3 o'clock position. That's the view. So you can assess the size, flow of the duct, and you can assess the LA ratio of the diastolic stream. So that's the three-leg view, the right pulmonary, left pulmonary, and the PDA. This is the main pulmonary artery, and this is the aorta. So the blood will appear red because it's flowing towards the from the aorta to the main pulmonary artery. Because the pointer is on the top, the blood approaching towards this pointer will appear red in color. So if there is further hypertension, you might see the other way around, the blue color or bidirectional flow. So this is again the duct. There's slight turbulence here because you can see blue as well. Yeah. As the duct narrows, you might see more turbulence. So various views of the ductal flows I think will be covered in the PDA presentation. Let's skip through this one. The crab view that we say, which we assess for assessing the pulmonary veins. We can see a bit of pulmonary veins when we are doing a subcostal view when we are looking into the left area. But crab view is the best one to assess the pulmonary veins. The parasternal long axis view, we put 1 or 2 stages higher and angle it inferiorly so that it's the pulmonary artery in the long axis. So that is the crab view because the one pulmonary vein here, one pulmonary vein here to the right side, the left pulmonary veins, lower one and the upper one. So you can see the 4 veins appears like a crab. That's it's called that. Those are the 2 pulmonary veins that you can see. So approaching these 2 veins will appear red. These other 2 veins will appear blue because they will be going away from the pointer. So I think just trying to show the PGA here. You can see 2 parallel flows. Normally I mentioned about the arterial crossover. Normally this should go in this angle and this should come the other way around. They should be at 90 degrees to each other, but here they are in parallel separation. That's the PGA. So I'll come to the end of my presentation. So we have to do segmental approach, like I said, first establish the situs and then going to the area into this. So the segmental approach. Always establish normal anatomy. Never assume the normal anatomy. It should be proven by our findings. And any abnormal finding that you see should be reviewed by a cardiologist. Yeah. Thank you.
Which is the one? So just Yes. You can.
Okay. So as you all know, my talk is on what is the role of neonatology. That and what they should know about congenital heart disease to diagnose it at right time. So congenital heart disease, as you know, is the most common congenital anomaly with incidence of 18,000 live births. And among these, the critical congenital heart disease are those who need surgery or intervention within 1 year of age. So they constitute 25% of total congenital heart disease, which is a significant number. Okay. So the main issue here is the delay in diagnosing these critical congenital heart disease will increase the survival, affect the survival even after surgery. So the role of radiologist is here to diagnose these babies with critical congenital heart diseases in the right time, without any delay, without they become unwell, so that they will have very good outcome. Because most of the cardiac surgeries at this moment, in most of the centers, they got survival rate up to 98%, and they can lead normal life, except the univentricular heart. Most of the heart diseases have very good outcome. But the key thing is to diagnose them early. That is the key thing. That is where the role of neonatologist is, to diagnose them in the right time. Okay, because the pediatric cardiac services are not available in all the cities. So it's very important that, in my view, the first step in diagnosing this congenital heart disease is where the clinical examination. Okay, first you should suspect, based on your clinical findings, clinical signs, that this baby might be having a cardiac problem. Then only you can do the echo. Okay, so the first step here is a good clinical suspicion. Like if you see a baby with poor perfusion and not responding to your routine treatment, like fluid bolus, not responding, and feeble similar perfusion, then you should get an idea. This can be a coarctation, this can be a critical aortic stenosis, this can be a hypoplastic left heart. So you should have the clinical suspicion first before venturing. So clinical suspicion is very important. Okay. And if you have a differential pulses, okay, good radial pulses, but poor femoral pulses, or differential cyanosis, 100% saturation in the upper lip, but 80% in the lower lip. Okay. And respiratory distress, not responding to treatment, persistent cyanosis. Okay. And if you hear a heart murmur, okay, or abnormal chest X-ray and ECG experience. Okay, these are all the things which will stimulate you to think towards any cardiac problem. So first step is always clinical examination. So as my colleague told about systematic sequential approach, what I do is I go sequentially. I don't go just so I go sequentially. First see the SVC IVC and establish their connection to the ATA, and then ATA ventricular connection. Then I review the ventricle and its ventricular section. Then I go ventricular arterial connection, that is aorta and the pulmonary artery, and see the wall. So you need to go systematically. Then you see the branch pulmonary arteries and the descending aorta. So if you go systematically, you won't miss. Okay, like the hollow aorta. Okay, then you don't miss it. So this is a class. I'm not going to go in detail about this classification because most of you know. Congenital heart diseases are classified into asymptomatic heart diseases, where you got left to right like ACE, PFA. And other is critical obstructive lesions like aortic stenosis, coarctation of aorta and hypoplastic left heart, and pulmonary stenosis, that's at the right side. And cyanotic heart diseases like the common 5T, tetralogy of PAPVD, and tricuspid. So these 5T. But the first heart problem, asymptomatic heart diseases, usually they don't present in the neonatal period. Okay, so they present after 4 to 6 weeks because of the high pulmonary pressure in the early neonatal period. Okay, because as you all know, fetal circulation is different. All the fetuses will have high pulmonary pressure. When they deliver, the pulmonary pressures are high. There won't be much stress. So the common age of presentation is 4 to 6 weeks of age. And the main goal is to diagnose these critical conditions. These are classified as critical congenital heart disease, where the critical obstructive lesions and the cyanotic lesions. These things you need to diagnose early, okay, to give a good outcome. Okay. So there are some clues, even though you go systematically, there are some clues, okay, which I follow. Okay, these clues will help you in diagnosing. Okay, as the PFO. If you see a PFO with right to left flow, you should you should look for some right side obstructive lesion. Apart from pulmonary hypertension, like PSPDC, tricuspid and right heart. If you have right heart obstruction, you are bound to have right to left stent across the PFO. So if you put a probe subcostal, if you see right to left stent across the PFO, you should not leave. You should make sure you don't have any conjunctivitis. Second is PDA right to left flow. So if you have left heart obstruction, okay, if you have critical aortic stenosis or coarctation of aorta, the systemic circulation is supported by the PDA. So you have right to left flow across the PDA. So if you see a right to left flow across the PDA, you should not assume it's just pulmonary hypertension. Okay, you should need to see aortic wall clearly. You need to see descending aorta clearly. And if you are not happy with the views, don't say that there is no coarctation of aorta. I can't see the views and get some help. Okay, so but very important. If you follow these principles, you won't miss a case. Okay. Then retrograde arch flow you see in and the most important thing I follow is if you have a chamber and vessel asymmetry. For example, if you have right heart dilatation, okay, then there is a problem with the left heart. So if the babies with critical aortic stenosis or coarctation of aorta, they have prominent right heart. Okay, if you have prominent left heart with a small right heart, that means there is a problem with the right heart. Critical pulmonary stenosis or something. Okay, chamber asymmetry is very important. You should not ignore. Our tendency is if you see a big right heart to label it as a pulmonary hypertension and start the treatment. Okay, don't assume that. Pulmonary hypertension is a diagnosis of exclusion. Once you exclude all the heart problems that can cause right side dominant, then only we should label it as a pulmonary hypertension. Okay. So I will give videos. This is the baby with shock, circulatory collapse, and this is the 4-chamber or 5-chamber view. You need to show the diagnosis. Okay. Okay. So. Okay, what do you think? The first videos are not saying, but we will see. What do you see in this? You need to talk whatever you are seeing. So what view is it? So this is apical. Yeah. This is left atrium. This is left atrium. And this is yeah. Please tell. What are you seeing here? No, this is mitral ligation. This is mitral wall. Yeah? And this is aortic wall. Can you see a turbulent flow across the aortic wall? This is aortic wall. Yeah? This is 4 chambers. So left atrium, left ventricle, and this is 5th chamber. Yeah? This is interventional. Okay, this is interventional. So there is turbulent flow across the aortic wall. Okay, this is going to be aortic stenosis. Okay, I think this critical aortic stenosis because if you see the left heart function is not good, it's impaired because of the critical aortic stenosis. The function is impaired. The patient presents with shock. So that if you continue to give inotrope and all, it won't help much. Okay, you should have a clinical perspective and do. So this is the bicuspid aortic wall, and I will put this later. Okay, this is another case with needed with shock. Okay, you are giving fluids, you are giving everything, but baby is not responding. Okay, and you can't feel the pulse. So you got the echo. So what are you seeing in this? Just to describe what view is this? Yeah, so that's very good. So he says the right ventricle, right heart is dominant, and ventricular function is impaired. That's very good. Okay, then when you see this, you should have there is some problem with the left heart. Okay, so then in your mind you should say, oh, right heart is dominant. I need to make sure aortic wall is good. I need to make sure descending aorta is good. Okay, otherwise, without seeing them clearly, you should not complete. You should not write the report. Okay. So this is the aortic arch view. What are you seeing? So this is coarctation of aorta. So this baby got severe coarctation of aorta. Okay. So in the anterior period and early period, right heart is supporting the systemic circulation. Right heart is supporting the pulmonary circulation and the systemic circulation. That's why it is got dilated. Okay. So you need to make sure you are not missing any coarctation of aorta. It is often missed because when your baby is crying and all, you will see up to here only. You don't see all the time good views. And you say aortic arch is good and you get to document. Okay, but you need to see descending aorta. Okay, behind the chest. It's very important. So this is the Doppler acrostic, and you will see increasing velocity up to 4 meters per second, and also diastolic change. Diastolic forward flow is classic of coarctation of aorta. Okay, this is a well baby. You can see the upper limb saturation, well baby. Upper limb saturation is 97%, and lower limb saturation is 81%. Okay, so this is what is the clinical sign? Differential sinuses. Okay, so what heart disease you suspect based on the clinical finding? Yeah, coarctation of aorta. Okay, so that's why I said clinical findings is very important. Okay, I think there is some problem. I can't play all the videos. This is a short axis view. Okay, in this view, you will see a small aorta, smallish aorta, and prominent pulmonary artery. Here, this is what view is this? Yeah. So, for the short axis view with pulmonary artery bifurcating. Okay, and here there is a clue. Okay, now everything is very good. So here there is a clue, and when you are seeing short axis view, if you see turbulent flow here, okay, that means there is coarctation of aorta. So these are all the clues not included in textbook. Okay, these are all my teachers told me, like how not to miss coarctation of aorta. When you are seeing a short axis view, if you see turbulent flow below the LTA, turbulent flow, that gives a clue that there is a coarctation of aorta. Okay, so you should get these clues. Okay, and if you see the whole 5-chamber view, okay, so this is pulmonary artery, which is from this is aorta. Aorta is smaller than the pulmonary artery. Here, right heart is dominant, left heart. Ascending aorta, can you see the transfer getting smaller? And here this is the coarctation of aorta developing. Yeah, it's not very tight. Yeah, and if you can see the ductal flow is bidirectional, and there is right to left flow and left to right flow. That means the duct is supplying the descending aorta. That's why we are getting the low saturation. Okay, so if you diagnose here, that's good. If you don't diagnose it and send the baby home, the PA closes and baby collapses and dies. Okay, baby is dependent on the PA. So it's very important. Okay, so here you should get with the baby is very well. You should get the suspicion with the differences.
longer time.
Okay.
You have time.
Okay, these are the three views. Concentrate on this first one. Okay, this is IoT cost view. Okay, second is the color, and third is the customer flow. Okay, based on this, what are your comments? Describe what you are seeing here. So concentrate on here. Yeah, this is better. So we will concentrate on these two. Okay, this is IoT cost. pulmonary evidence. If you are in doubt, you should get help. Nowadays, it's very easy to get help. You can make any card and send it to anybody you know, Hari or me or anybody. Just send it and in the WhatsApp you can get the diagnosis. But you need to be active.
Yeah,
And this video will show, will demonstrate how we use it. Okay? This is a common mistake, we did when we are training and we did when we saw when our senior consultant did it. So you have seen a right to left flow across the PFO. Okay? And what is this red flow? What is this red flow? Pulmonary venous flow. So this is the common mistake we did. Okay, as a trainee, this is a common mistake even the senior cardiologist. So what happens in PFPVD? This diagnosis is clear. Intracardiac PFPVD will go through. But the mistakes I did and we did is usually because the right side heart pressure is very high, you see a right to left hand across the PFO, it hits the roof of the left atrium. It hits the roof of the left atrium and comes down. And when we do the scan, we all assume there is a pulmonary flow because you are seeing the red flow coming from the roof. We see, so you don't get misguided. But this is a common way. So, even we use the, so I have seen the pulmonary venous flow, how can I treat PFPV? Then when we review it retrospectively, all the time, most of the time, PFO flow goes and hits the roof of the left atrium and comes down. The moment you see a red flow coming from the roof, you assume it as a pulmonary venous flow and say, ruled out PFPV. And that's a common mistake we do. Okay? So from now onwards, if you are doing a scan for a clinical condition like that, don't get misguided by that. You need to see a pulmonary vein coming individually to the left atrium. Then only you can say diagnosis is student. If you are not seeing it, you can see PFPVD can't be ruled out. Medical level, we should be very accurate now. Okay? Don't get fooled by these mistakes. Okay, these they won't describe. These are all the experiences. People make mistakes and we pass it on. So here they say if you see there is a pulmonary venous flow, we can say it is not TAP, but this is actually TAP. I will show you. Okay. So and if you see it posteriorly, you will see a what are you seeing here? This is another clue. Okay, first clue you got the point of PFO flow hitting and mistake. Second clue is here. What are you seeing here? Here? Yeah. Okay. So this is the confluence. Where is the left atrium? Completely. Okay. That's good. So this is the left atrium. Okay. So yeah. So another point is, don't with one view don't make a decision. You need to speak posteriorly, anteriorly, and many times the confluence is not as prominent as here. It will be very thin. And the lesson, my teacher told me, still I remember it every time. Is if you see any chamber or structure behind the left atrium, okay, that must be TAP. Okay, you should not see the structure you see behind the left atrium is aorta, nice arterial aorta, round structure. Okay, but if you are seeing anything between the aorta, so here I will show you. This is descending aorta, round pulsatile, and this is left atrium. This is confluence. You should not see anything behind the left atrium. Behind the left atrium, descending aorta. That's it. If you see any extra structure behind the left atrium, you must say it is the PFPVD and you should establish the pulmonary veins going into that and all. Okay. There is another rare condition where you can see like absent pulmonary valve syndrome, that's the pulmonary artery also you see sometimes. But because it is so rare, don't worry about that. But if you see any chamber behind it, then assume it is PFPVD and look into the pulmonary veins draining into it. Okay. This is the second lesson. One PFO flow. And any chamber behind the left atrium, you need to do. Okay, these are all the clues. And if you track that confluence, in the liver, you can see that the descending vein. No, this is liver. Okay. So this is liver and this is the that contains going into the IVC. Okay, you can see dilated IVC entering into the right area. Okay, if you see dilated IVC means there is something else going into that. If you see dilated SVC, there is something going into the SVC. Okay, so these chambers, when you are seeing the cytoplasm and all, you need to think about it. These IVC is normal size. If you see a confluent, normal size IVC, but big SVC, then you should think it is supracardiac. Okay, this is the intracardiac PAPVD. You can see the vein coming down and opening into the IVC as well. So this is another echo picture. Okay, this is another echo. Can you see the left atrium? And what is this? Confluent. And what is this? Beginning area. So here you see a small picture. Sometimes it is so thin that you want this describe. Right? So thin. So you need to be very clear taking the place. Okay, baby with low saturation and mild distress. So what are we seeing here? Just concentrate, don't concentrate on the text. Here. So what are we seeing? Just describe, question for you. Yeah, direct right side. Then you need to think about PAPVD and coarctation of aorta left side obstruction. Okay. So then what are we seeing? What is this? What is this chamber? No, this is LA. And what is behind it? Confluent. And behind it is the descending aorta. Okay? And that confluence, if you follow that, the confluence flow is coming down and entering into the right atrium. So that's the coronary sinus PAPVD. That's where the coronary sinus is. Okay? So if you see this structure of the heart, these are the pulmonary veins, and the small vein below it, between left atrium and left ventricle, posteriorly is the coronary sinus, and it opens into the right atrium. If you have coronary sinus PAPVD, these four pulmonary veins confluence and enter into this coronary sinus and give rise to coronary sinus PAPVD.
Government people might come, please everybody wear a mask. Number one. Not one. Number one. I request 2 minutes. Okay, everybody take your RFS app. Put it into the group. Because everybody is in the group. Who is not there in the group? You are not there. Who is the PG? Our people. Answer into the group. Right now, put it your all vaccination. Vaccination certificate. वो डाल दीजिए अभी इसी वक्त डाल दीजिए. It's your permission. And must just I'll take 2 minutes. Mohit and Vikram and I call always Anna. She's very senior. Okay. You know, see, you know, anybody guess his age, please? Anybody guess his age? Anybody? Wow. I don't want it now. Okay, so senior, so learned and genuine and just I asked P.P. Ramanov, can you just, I need a funds because of the corona, it's very difficult to do the program. He told only one thing, never asked money, just 1 second, he never asked. He told, Tamuru means brother, younger brother. I am there, go ahead. And really, because of this program is going to happen, we got all the speakers. Kochika, correct? Yes, sir. Yes, Kochika and what is it, our TV and Vikram and David. So, all these people are there because a big round of small applause. And only that is the master of masters. And I keep on about that. And he is very handsome and learned, and everybody knows who he is. Okay, Dr. Mohit. Okay, everybody has come. Today, every person is going to get one call. Everybody. Here. Thank you. Please, whenever they take government photo, ask. Thank you. Sir, namaste. Ravi kada?
Revant.
Sorry.
Okay. So this is another case of baby with low saturation and mild distress. Okay, you can see prominent right heart again. Then you need to think about PAPVD. And here you can see a complaint just below just behind the left atrium. Okay, and you follow it. What are you seeing here? Okay, can you see the complaint? Yeah, with all the four pulmonary veins. So this is the crab view. Four pulmonary veins going into the complaint and going up ascending vein and innominate vein into the ST. Okay, it is supracardiac PAP. Okay, here you can see the CT scan picture. Which this is the ascending vein, innominate vein, and IV. Okay, that's the supracardiac PAP. That's how you get the figure of 8 experience. Okay, so the lesson here is PFO with right to left hand should give you a clue. Dilated IVC or SVC or coronary sinus should give you a clue about how the pulmonary where the pulmonary veins are going. And if you see any chamber, okay, behind the left atrium, we should suspect a PAPVD. And then these chambers are this extra chamber is not always visible. We need to look for it. Okay, and don't get fooled by the flow coming from the roof of left atrium. Okay, that is a common mistake.
Sure. Yeah.
Okay, this is another case. Okay, so this is a very rare case. I will keep on to this thing. So this is a case with dilated RA and RV. So there are other conditions where you get dilated RA and RV. Okay, and so far we covered left side obstructive lesion and also PAPVD. Then third is rare is if you have any AV malformation like brain and liver. Okay, brain is vein of Galen malformation, liver is liver AV malformation. Okay, so when you see the dilated right side, I simply scan the brain and liver also to rule out. Then only I will say it is PPH. Okay, first coaptation of aorta or second PAPVD, third any brain AV malformation, liver AV malformation, and then diagnosed as PAPVD patient. So this is a case of vein of Galen malformation. You can see the brain showing that is a vein of Galen malformation. Okay, most of you know how to. So this is a vein of Galen malformation in the middle. Okay, because of lack of time, I am skipping it. And this is the case with the liver AV malformation. So this is subcortical view where we see the liver, and if you put the color flow, you will see multiple vascular structures, and that should give you a clue that it is a brain, liver AV malformation. If you see a dilated SVC without PAPVD, then you should suspect vein of Galen. Okay, if you see dilated IVC, okay, then you should suspect hepatic AV malformation. Okay. So in my view, significant with the right heart dilatation. First, we need to rule out PAPVD, coaptation of aorta, AV malformation. After excluding all these only, then you should label it as severe PA. Okay, that is the lesson. Okay. So, okay, this is a cyanotic baby. Okay, what are we seeing in this? What structures you are seeing here? What structures you are seeing here? What is this? Huh? This is this is apical view. This is what is this wall? Okay, this is left atrium, left ventricle, and it should be iota, but what we are seeing here, there is a great vessel coming and bifurcating. Yeah. Okay. So don't assume that every vessel coming from the left ventricle is iota. How to differentiate iota and pulmonary artery? Yes, pulmonary artery bifurcates. Ascending aorta just goes up and gives head and neck vessel. Okay, like an arc. Okay. So here you can see pulmonary artery, like you can see a great vessel coming from left ventricle, which is bifurcating. That's the pulmonary artery. And you can see from the, if I sweep anteriorly, you are seeing a RV giving rise to a great vessel which is not bifurcating. That is iota. Okay. So right ventricle is giving iota and the left ventricle is giving pulmonary artery. What is the diagnosis? CGA. Another clue is what we said is great vessels usually in normal position they crisscross. Here it is they are parallel. So then that is the another clue. Okay. So this is the same baby. What view is this? What view is this? Long axis view. Okay, here another clue. This is no, this one. Left atrium. This is this structure. Left ventricle. Yeah, can you see the branches? Here one and here one. Another clue here is in a normal baby, when you are seeing the long axis view, if it is iota, usually iota goes anteriorly. Okay. In normal, aortic wall, if it is aortic wall, it should go like this in this direction. Yeah. But here you see a great vessel which is not going in this direction. It is going posterior and bifurcating. Okay. And that should give a clue that it can be a PG. Okay. And second clue here is you see a pulmonary artery going posterior and bifurcating, and then here you can see a iota coming out from the right ventricle. So that's a clue that it is a PGA. Parallel vessel, double barrel gun set. Okay, all these descriptions are there. But if you see a parallel vessel in long axis also, it's a PGA. Okay, if you follow it up, you can see like this. Yeah, pulmonary artery and aorta parallel to each other. And in the short axis view, yeah, in the short axis view, you will see the pulmonary artery which is posterior, which is dividing into right pulmonary and the left pulmonary. Aorta is anterior. Okay, but in the normal baby, aorta is posterior, pulmonary artery is the anterior most structure in the heart. Okay, so these are all the clues. And most important is clinical suspicion. A cyanotic baby very well not in distress. That should give a clue we are dealing with a cyanotic heart disease. Then so you should have that 5 T's in a differential diagram. Clinical suspicion, 5 T's in the brain. Then you do the scan. Don't do it blindly. First clinical finding, make a map and then put the probe. Then it is easy to make a diagnosis. Okay. You're asking something. So this is a PGA. This is normal crisscrossing in a normal baby. Here parallel vessel, pulmonary artery coming from left ventricle, aorta coming from the right ventricle.
Videos are there.
Okay, same view. So these are other echoes. I will skip it. There is another cyanotic baby. Okay. What are you seeing? Can you describe? Okay. Videos are not playing. Okay. Some problem videos are not playing, but I will tell you. This is 5-chamber view. Left atrium, left ventricle, and aorta. Okay. Okay. Oh, now it is playing. Yeah. So can you see?
Then we have to press the escape and
So this is left ventricle, right ventricle, and aorta. Okay, and this is sorry, left ventricle, right ventricle, ventricular septum, and here is the aorta, and this is the VST. Okay, so you can see a perimeter as VST, and also you are seeing a aorta overriding. Okay, and aorta is getting the flow from both right ventricle and left ventricle. Okay, to the aorta. So left ventricle, right ventricle, interventricular septum, and here is the VST. From here to here is the VST, and aorta is overriding the. If you see this picture, you should have one diagnosis in your mind. Okay, then you go to the next. In the long axis view, you can see the ventricular septum, left ventricle, right ventricle, and this is aorta overriding. Okay, overriding the VST. Okay, so that should give a clue that it can be a tetralogy of that. And then you do the short axis view. You can see, so usually you will have a circular aorta, but here because of the VST, you can see a VST. And this outlet septum is deviated anterior superiorly, causing severe RUOT obstruction. So this is the RUOT obstruction. Okay, and if you see a continuous wave, you are seeing a 4 meters per second. So pulmonary stenosis. Okay, so this is a tetralogy of valve. Okay, VST overriding of aorta, pulmonary stenosis. Okay, with the clinical findings, tetralogy of valve, you will see ejection systolic number. It should support your clinical findings also. Okay, so this is another cyanotic baby, well baby, but low saturation. Just to describe what you are seeing. Just to describe what you are seeing. So what view is this? It's a what 4 chamber view? Yeah. Okay. So what are you seeing? Just describe. What is this? What is this? What is this? Mitral. What is this? Yeah, definitely. What is this? Right ventricle. What should be between right atrium and right ventricle? Can you see tricuspid wall? So you can't see any tricuspid wall. What are you seeing? You see a ridge. Okay? Because so what is this diagnosis? Tricuspid ridge. So if you don't see tricuspid wall and a ridge across it without any flow, that should give a tricuspid ridge. Usually, most of the time, tricuspid atresia associated with ASD, VSD, sometimes PGA, etc. The whole lot of combination can happen with the tricuspid ridge. But this 4 chamber view should give you a clue that it is a tricuspid ridge. Always go systematically. That's what I am saying. Veins, atria, atrioventricular wall, mitral wall, and tricuspid wall, ventricles, great arteries, and then you don't know. Okay, so keep this. We are coming to the end, and final key is the truncus arteriosus. In the embryonic life, we have 2 great vessels, aorta and pulmonary artery. But in embryonic life, they come from single vessel called truncus arteriosus. Single vessel comes and it goes up as the aorta. And from here, from the ascending aorta, you get a main pulmonary artery dividing into 2. Okay, that is truncus arteriosus. That's the embryonic life. So failure of septation will lead to persistence of truncus arteriosus. Okay. So this is an example of truncus arteriosus. Unfortunately, it's not playing. You can see this is a trunk. Okay, going up.
You can click with this. Yeah, click it. Done, sir. Open shop.
What you are seeing here is this is aorta. This is a truncus going up as an aorta. But you can see from the side there is pulmonary artery
not been there in the artist.
bifurcated.
Okay. So when some of the videos are not rooted there.
So this complete is the truncus arteriosus. Going up as aorta. From the side you are getting 2 branch pulmonary arteries. This is left pulmonary artery.
It has to be reinstalled.
Right from there.
Or
So as a definition, iota does not have any branches except small coronary artery. So these are all the clues. Iota doesn't have a branch. The only branches it gets is coronary artery. If you see any branches apart from that, that can be frontal artery. If ascending aorta is giving prominent branches, you should say it is frontal artery. Okay, this is and we are coming to the last slide. So this part, can somebody comment? Okay, left atrium, right atrium, left ventricle, right ventricle. Okay, left ventricle is very small. That means it is a hypoplastic left heart syndrome. So always go systematically, and the ascending aorta is very small, like 2 millimeters. So hypoplastic left heart is usually associated with aortic problems. And this is hypoplastic right heart. If you see in the pulmonary artery, say inside ventricular septum or the system PA, the right ventricle is very small. And they are very, obvious. When you see a four-chamber view, one chamber is very small, one chamber is dominant, then you see so in conclusion, lack of time, these are the most important points. Clinical, first step is always clinical findings, clinical assessment, and suspicion is the most important thing than doing echo. Okay, first most important is clinical suspicion. The second one is when you are starting an echo, before starting, this is the lesson I learned. Before starting the echo, you should have a differential diagnosis in the brain. Before starting the echo, based on the clinical findings. Otherwise, don't start. You assess the clinical findings, have some differential diagnosis in the brain, then put the probe. Okay, your eyes won't see what your brain doesn't know. Like, so you should have some idea what we are doing. Then put the probe and investigate what diagnosis. Okay. Systematic sequential analysis is very important. And the most important is while going through the presentation, I told you about some clues, how to diagnose. And stick to remember those clues. Always consider those clues while you are doing. In doubt, don't just make a diagnosis. If you are in doubt, get help. Now there is a technology. WhatsApp is there. You can record a clip and send it to anybody. And everybody will be happy to help you in getting the diagnosis. And I do it every day with all my colleagues, neonatologists. Okay? And most of the time, 99% of the time, we get the diagnosis with WhatsApp clip or some sort of suspicion. Okay? Thank you very much for this.
Those things that you have like our workshop and you go and whenever you feel doubt, always with the help of theory. I was seeing one comparison tool. I was doing an echo, I told I was in a hurry. I just sleep, edit, no, normal. My colleague, he told no, sir. This is TJ, clinically this is TJ. Please see it again. And then I stood there, saw it was a TJ. So the clinical diagnosis, your clinical diagnosis cannot be wrong, your echo can be very, very wrong. So next speaker is Dr. Ankit is three for some issues. I will take that short film. I will take that. Thank you.
Good afternoon, everyone. So there is no coffee break because we are running late.
कॉफी यहीं दे दो ना सीट पे Where you got the coffee from? I went to the restaurant. Yeah. I was just moving around and found it. Great.
So, you people are clear with this thing. Use normal and abnormal, we need to differentiate. Okay, so that is very important. Once you are clear with the views, okay, then we can, progress in further. Like there are 3 or 4 issues in the elemental cardiac issues. One is shock. What is the other one? KPHN. What else? PD. So these are the main issues, 3 main issues which we normally feel. So that's why in this workshop we have kept that what are the different parameters. Once you are through with your normal views, what are the different parameters by which you can assess that how bad is the shock, okay, which inotrope we need to use. And we are not going to talk about any inotrope or management in this, but this is just for views that with what you will see there, okay, so that you can assess this is bad shock, this is, I won't say good shock, but lesser bad shock. Okay, so that is something you need to see, and similarly with the PPD and similarly with the CPH. Okay. So in all these workshops, I've been going through this ultrasound, and you don't have kept the basic because this is advanced. So we suppose that you know the basics. So that's why the parallel sessions were going on in those 2 workshops regarding the basic, what is ultrasound and what is the probe. Okay, so this is all. So all your workshops start, all ultrasound workshops start. That where you need to keep the probe rightly and correctly. You should know where to keep the probe. So that is very important. Okay, so we just start with one basic physiological thing. Then I talk about functional echoes. Okay, we talk about the cardiac output. That is what we are interested in, because what is your blood pressure and all those things are clinical things that can be useful, but they are not fully reliable. So to substantiate that, what we do is we try to calculate your cardiac output. So cardiac output is, everybody knows, is stroke volume and heart rate. And what stroke volume depends on preload, afterload, and contractility. Okay. So these are the 3 things we will be assessing by echo in the brain. Okay. What is the contractility? What is the preload? And what is the condition of afterload? Because on that only your tissue perfusion matters. Okay. So your tissue perfusion is everything, because that's what now we are interested in. So to know about the cardiac output, we calculate LVO, left ventricle output. The other way we do it is superior vena cava flow, SVC flow. This came into fashion, like in late 90s and early 2000s, when Martin Krukov and Nick Evans, they published a lot of papers on this. So then the reliability of that parameter is diminished. There are many reasons behind it. We will talk about that, why it is diminished, but it is not that reliable if I take that parameter as a single parameter. So what I need to do is I need to combine it with the other. So you need to calculate that. You need to measure the SVC flow, but it has to be in combination with the other parameters. One is LVO, that is left ventricle output. It becomes unreliable if you are HSPDA, hemodynamic significant PDA. Your baby is in shock with HSPDA, hemodynamic significant PDA. So if I calculate my LVO, my left ventricle output will be sky high because it is volume overload of the left side. So what happens is your volume, what you are getting in LVO, will be in the range of 500. But your tissue perfusion is not good because there is a systemic hypoperfusion going on because of shunting of blood through hemodynamically significant PD. Capital C in what we say, isn't it? So that is one thing. Because of that only they brought this SVC flow. And next thing is SVC. And then it is not only the left ventricle we are interested, isn't it? Because we are interested in right ventricle also. Because if right ventricle will not push blood in the lungs, then how come the left ventricle will get the blood from the lungs? You are getting my point? For your right ventricle, what is your preload? From where the blood is coming in the right ventricle? Yes. So superior vena cava, inferior vena cava. So there the blood is coming from your body, isn't it? So your preload for the RV is your body. Okay. Then what is the preload for your LV? LV, from where the blood is coming to the LV? Lungs. So if your RV is not pumping the blood in the lungs, then you will not get the blood in your LV unless and until there is some this thing, structural anomaly. It is a normal structure. Now what all we will be talking, it is normal structure. So that's why you need to have a good functioning RVO. So that's why we will be talking about RVO, right ventricle output also. Okay. Then preload, we will be, as we talked about, we will be assessing the preload through inferior vena cava. And then the final thing is contractility.
Good morning, everybody. I am Dr. Ranjan Pijawar, and I'm glad you all are here, and you have the opportunity to learn from the top experts of ECO, Dr. Mohit Saini, Viktesh, and many others. So, utilize their expertise, learn, and then request them whether you can be in touch with them so that if there is any problems when you do the echo, you can always say, can I send this image to Mohit? Will you tell us what is it, or if my diagnosis is right? So continue keeping in touch with them. That is also important. And don't be slaves of echo. Sometimes if you go to a place where there is no echo, don't forget the clinical cardiology of the voice. Keep that. Correlate. And once again, thank you, and all the best. I thank all the faculty who have come from far India to conduct this workshop. I think quite a few went on to online after the scare of on the cure. But then there is, it is very well. Yes, very true social distancing here. I always get intrigued, when the air hostess, when the plane stops, and she says, please maintain social distance while getting down. For 2.5 hours, we have been sitting next to each other. And then while getting down, they remember social distancing. So sometimes it is all a, convenience, rules according to convenience. But yes, we must take precaution. And I see all of you with the mask here. Well done. Thank you.
Okay, so let's start with this. What is preload, contractility, what is afterload. Okay.
No, control it.
और आपने ऑफ किया
So it is not being playing. Let's go for the. So whenever we talk about the cardiac outputs, fine. So these are the few things we need to look at. Left ventricular output, HVC flow, RVO, and the body fluid status by assessing the IVC. So this views you are clearly, I mean, it's just a revision. Okay, these are the various controls. So what is this view? Apical pipe chamber, isn't it? And this is where you will keep the flow. Okay, and this is how you will see it. It is upright, not inverted. It's anatomically corrected upright. So this is your aorta. So when you calculate the Doppler in aorta, you need to keep the pulse rate Doppler here just above the aortic wall here, and then you will calculate the VTI. This is what is the VTI. Here you will calculate. So VTI is velocity time and temperature, and this is the formula to calculate your LVO. Pi r square, where r is the radius of the aorta, heart rate into the VTI which you have just calculated divided by rating Q6. This is how when you get that, we will show you on the workstation. This is when you get this Doppler flow of the aorta. This is how you calculate the VTI. Okay. And then this view is basically to calculate the radius of the aorta. So this is parasternal long axis view. This is where you will keep the probe as it is shown in this video. This is how you will see it. And now you can appreciate this point. This probe orientation marker is up, not down. So this is a flat view, and this is where you will calculate your aortic diameter. From this point to this point at the level of aortic valves, and the valves are open like this. So this is how you will calculate your diameter, and the half will be the radius and the radius. So this is your formula. Okay, your aortic diameter means if your aortic diameter divided by 2, if you do it the whole square, then how it will come. Or you can make it half and then pi r square into heart rate into VTI divided by your weight in kgs. It is also known as the cardiac index. Okay. Why we need to divide by the weight? Because suppose if I get some figure for 1 kg baby and get some figure for 3 kg baby, it will be different for different babies with different weight. So that's why to divide it with the weight is very important. Okay. Now the question for you. You need to do this exercise. This is 28 weeker, 980 grams, 0.98 kg baby. Heart rate of 168, aortic diameter of 0.62 centimeters. Aortic VTI calculated is 10 and pi value is 3.1.42. What is the LV index or cardiac index of this baby? If you put these values in the machine can calculate. But if not, then you have to manually calculate these values, see the values and manually calculate by yourself. Anyone? 5 and 7. Yes, it is 5 and 7. Okay, this is how it is being calculated. Okay. So what is the significance of this? You have a preterm baby 28 weeker, 980 grams. Left medical output or left in the LV index is 517. The normal value is actually it is from what we take in our studies, what we are taking is 125 to 310 ml per minute. So it is low or high? High. Then what can be the issue? PD, HSPD, even I because the volume overload is like if I don't see even the PDA, if I just calculate my LVO and see in a apical port chamber that LA-LV is dilated, this is my left ventricle output index. So it is volume overloaded. The most common reason for preterm baby with 900 gram baby will be my PD. Okay, so you should be well aware of this. Yeah, so that is here is the point. So this is the one technical point which I didn't think of because I thought that PDF will keep it, but this is very important. So what we say is that your ASD or PF4 size is more than 4 millimeters, then there will be shunting from LA to RA. Okay, so the amount of LVO you will get will be under Okay, so it will be under assessed. So that's why if your PF4 ASD size is less than 4 millimeters, then it is reliable. But if your size is more than, because your LV will be bloated like this, if the volume overload is too much. So what we say is if your size of ASD or PF4 is more than 4 millimeters, 25% of the blood from LA, instead of coming to LV, it goes to R. So then your LVO, what you have calculated, will be under assessed. Actual what should have been, it is under by more than 25%. So it has to be smaller. Your PFO or ASD size is smaller than 4 millimeters. It was a very good point this sir has brought out. So this is one thing we need to keep in mind. Large ASD, very large ASD. Yeah, but the thing is, and what happens is, what is the difference between in pediatric age group or bigger babies and newborn is, so your right-sided pressures are physiologically higher as compared to the bigger babies. So the effective shunting of ASD, even your size is bigger, is not that much in newborn babies because your physiological high pulmonary pressures are resisting that. That is one way. That's why your even with large ASD, your newborns does not present very early. They present late. Many times happen your ASD is there, and if a large ASD, then they present in pediatric age group with bigger RA and RB because of volume overload of RA RB. But it happens later. Am I right? Because I don't have much of the experience for pediatric age group.
We see 40, 50-year-old adults presenting.
With
Very large.
So now the question is, this one thing is clear with everyone. Now the question is, if I can calculate my LVO, then why I am bothered about calculating my SVC or RVO? RVO, I still, if it is shock or it is shock because of PPHN, I know I need to know the outputs of my right ventricle. Then why I am concerned about my left ventricle outputs, if I am able to, because the reason is, if you have a big shunts at atrial level or at a ductal level, okay, then they are faulty. They are not actual representation what the body is getting. Why? If you can see with this diagram. Just concentrate on this diagram. This is very important. See, this is your LV. This is your LA. This is your RV. This is your RA. Fine. So now see. This is your lung. This is your body. Fine. From body, this is what? IVC and SVC. This is coming into your RA, going to RV, and then it's going to the lungs. Clear? This is your lungs. This is your pulmonary veins. From pulmonary veins, the blood is coming to your LA, going to LV, and then going to the body. Fine? If you think 100 ml of blood has come into RV, okay, and 400 has gone into LA. Okay, why it is happening is there is a PDH disconnection is here. Fine. What we are doing is when I measure my LVO, what I do is I keep my probe here and calculate my BTI. Clear? The PDH after that place where I am measuring that flow of the what we call is LVOT, that ventricle outflow tract. Okay, the PDA is ahead of it, so the blood has not shunted yet. So whatever BTI I am measuring is before that ductal shunt here, just when the aorta is started from LV. Okay. So if I measure there, what I will get is that the blood which is going out of LV is 400 ml. But then after that, 300 ml is shunted from PDA and has joined in the pulmonary artery. Okay, and gone into the lungs. So instead of 100 ml going into the lungs, it is 400 ml which is going. And instead of 400 ml going into the body, only 100 ml is going. But what you measure is 400 ml. Now you got my point? Why there is a fault issue with this? So that is an issue. So that's why, suppose if do it at SPC level, okay? IVC or SPC level. It will show 400. Isn't it? See, This 400 is coming from the lungs. Oh, sorry. Yeah, gone to the this thing. This thing is gone into the lungs. Okay, 100 plus 300, and then came back, and then you measure through SVC. It will be 400. So what we thought, it will be actual representation what the body is getting. It is not exactly the numbers like this. This is just to make you simplify, make the thing simplify for you. It means what actually the body is 100 from SVC. Yeah, SVC. But so yeah, sorry. It will be 100 from SVC because that what actually the body is getting. You got my point? Because the 300 when it gone through the PDA, gone into the lungs, the body has received 100. SVC will measure only the from the upper part of the body, but in newborns we think it is 70% of the total. So actually it will be around 70-75, but it will be close representation what the body is getting instead what you are getting through the LV. Got my point or not? So that's why people doubted that if you are hemodynamic treatment PDA, you should not be relying on your LV. Definitely. Clear?
Can we do the in that case? Can we do the pulmonary aspect? Give both the
Yes. So I will be coming there also because then we will get a very good VTI. But then the issue comes when we try to measure the size of the pulmonary. So while there is an issue with the, I will be coming to that also. While there is an issue with measuring the size of the pulmonary. So now I've come into which is this view. Views you have done. The kind of vision. What is this view? Subcostal cross-sectional view, isn't it? So again, the other thing which you will be seeing is the point pro-orientation marker is down here. This is what we have been taught in universal cardiology that make the thing simplified. Near to the probe, you have RA near to the probe, just to make anatomical orientation. So this is your RA, this is your LA. So your SVC will flow into this like here. And then you can measure the BTI of SVC in this way. Okay. So it will be something like this. Can you see this? The subcostal atrial view. Okay, the pointer is pointing at 3 o'clock position. And with pulsar Doppler, as SVC is entering your RA, you can measure just at the junction, you can measure the BTI. The basic formula remains the same. Pi r square into BTI into heart rate divided by the weight of the baby in kg. That r will change. If it is LVO, the r will be of iota. If it is SVC, the r will be of SVC. If it is RVO, the r will be of pulmonary artery, isn't it? That thing only changes. Okay, and there are different views to calculate that. So this is your SVC flow. You are measuring your BTI index. Fine. Now, as I told, there are two basic principles of ultrasonography. One, whenever you are trying to measure the Dopplers of any vessel, the flow of that Doppler or the flow in that vessel should be parallel to your ultrasound beams which are going through your probe. Okay. Now you can see the probe is down here like this. The flow is flowing parallel to it. So that if you want to do the Dopplers of any flow, the beam has to be parallel to that. And when you want to calculate, measure the size of any particular part of the heart, your ultrasound beam should be perpendicular to it. Because we have skipped that basic ultrasonographic lesson in this, because this is supposed to be advanced, so we know this. So because there is as per the resolution, so it all depends on your axial resolution. So for your axial resolution to be the best, your beam should be perpendicular to the structure for whom you are trying to calculate the size. So that is the problem with the pulmonary artery, because there is no view in which your pulmonary artery is totally perpendicular to the beams of the. So that's why whenever you're trying, when the people they did it with CT scan and MRI, and they did it with echo, there is always a difference in the size of pulmonary artery. So that's why your RVO does not become reliable. That is a big issue with the RVO calculation. So in this HPC, now you have calculated this UTI of HPC in this view, right? This is how you do it. This is from where you are. This thing is actually, and this is how you will see the. Now you can see the shape of the wave of left ventricle output aorta was different from this, isn't it? But we have read in theory there are 4 waves in HPC, isn't it? A, S wave, B wave, and the A wave, which is reverse wave. Why this happens? Because HPC is a vessel which varies with your respiration, isn't it? The size increase and decrease with your respiration. Okay, when you get negative intrathoracid pressure, it gets down, it goes in negative. But for the practical purposes, what we have to do is we have to calculate all the positive GTI, the area under the ground above, and minus the one which is down there. But it is so tiny that we practically don't take it into consideration. So we just calculate the GTI of those waves above in one cardiac cycle, and we take that GTI. Clear? Clear? Great. Then next thing comes, now I want to calculate the diameter of SC. So that is a kind of high peritoneal view, so it's a kind of modified short action. So your pointer will be just above the nectar line towards the left side of the sternum. Pointer is facing at the 12 o'clock position here. And then you will be sweeping it towards your right side. Sweep towards the right side. Okay? This is what this picture is showing. This video will show. This is how the lights are there. This is how you will see. This is your HPC. This one. Okay? Then you have to do the M mode in this because this is a variable. This is how it will look like. Okay, here your M mode line will come. M mode is motion mode. Here, and this is how it will see. So what you have to do is you have to calculate the minimum size and maximum size and take an average of it. This is very important. So you have to take the average diameter of HPC and then you take the radius out of it. Clear? And again the formula remains the same. Pi r square into heart rate into DTI divided by the weight of the baby. And the normal value, the normal range of SVC outflow is 41 to 160 ml per kg per minute. Okay, as you can see, because it has to be 2/3 of your body outflow. Because SVC flow is basically mainly from brain and neck and head. Yeah? But as I was talking about, there are pitfalls in this. What are those pitfalls? One, there are a lot of series of publications there, but there are no, if you are doing SVC flow and I am doing SVC flow, there is a variation. And the mainly where the variation comes when we calculate the size. Because when we do studies in sonography or in echo and all this, we talk about variation, okay, variability. The intra-operator means if I am doing the same value for 5 times, there will be a variability each time, but that intra-operator, same person doing the same reading for 5 times, that variability should not be more than 15%. And there is inter-operator variability. If you are doing that measurement, I am doing that measurement. That variability should not be more than, some papers say 25%, some papers say 30%. It should not be more than that. But when people try to extrapolate those studies, there is a lot of variability in that. So when somebody, you are doing that measurement, it was 50% variable from my measurement. So it was not reproducible as it was being done by someone. So that's why it is not reliable. That inter-operator and intra-operator variability was very high. So that was the main reason for this. You got my point? Understood? Great. So people try to do it with MI, but again the thing is there is no single parameter in neonatal hemodynamics which will give you the answer. You have to do everything. So when I try, when I get a baby in shock, I calculate LBO, I do SVC, both. Just whether they are correlating or not. That is very important. Okay? This is what we are doing. Okay. So now you are clear about LBO, you are clear about SVC. We have to calculate single, that parameter is not reliable. So it has to be combined with each other. Then comes this RBO. Okay. Again, I've told you the basics. So this is a Terraform long axis view, and this is, there are two sweeps in Terraform long axis view. One is sweeping up. So sweeping up is, this is what has been shown here. Okay, so my hand is just sweeping up. See there, isn't it? So that is your pulmonary artery sweep. So as you can see, that aorta which was there, it has gone and perpendicularly you get this pulmonary artery. So this in fact rules out one anomaly also. This sweep rules out one anomaly. What is that anomaly? So that rules out they are both perpendicular to each other. Sir, and sir also showed that double barrel gun view, what we say is easy. Okay, that is one thing. This is how you can do the Dopplers in this. But you know, whenever we do the measurements of pulmonary artery, we do it in this view. And as you can see, structure is vertical. My ultrasound beams are vertical, so they are almost parallel to each other. They are not perpendicular. There is not even a single view in cardiology in which we can have pulmonary artery perpendicular to the ultrasonic beam. So that's why the calculation of the pulmonary artery Doppler is not required. So this is for aorta. This is again, you can do it in apical four-chamber view. Okay, if you sweep up, you get apical. Which view? After four-chamber, if you sweep up, what view you get? Five-chamber. So then, if you sweep further inferiorly up, as it is done in this video, this is what you will get. This aorta is gone, and then you instead perpendicularly you are getting done another artery there. That is your pulmonary artery. This is your pulmonary artery view. This is your Doppler. You calculate that again. Okay. But one thing is there. If you cannot rely on the diameter of pulmonary artery, one thing you can do. This will give you a kind of just an eye overall view. So what we do is Dopplers you can do very well for pulmonary artery. When you do the Dopplers of pulmonary artery, and if your VTI of the pulmonary artery is less than 4, okay, that shows is a low cardiac output. If your VTI is more than 4, it shows your outputs are okay. So this is one very quick parameter. Now, if I am having a baby with PPHN, okay, there are other things in advance. One lecture is there, the taxi and all that stuff is there. We'll talk about that. But if I want to quickly see whether outputs from the RV right ventricle are going okay or not, what I do, I quickly go to this pulmonary artery view, do the Dopplers. If my BTI is less than 4, it means it is functioning is less, the outputs are less. And then comes your LV functions, left ventricle function. Okay, we have to calculate systolic function, diastolic function, and both together. For systolic functions for both LV and RV, and then if I talk about LV, okay, first and foremost thing that video did not say, you have to look at, once you keep on doing an echo, you get to get the sense how is the contractility. Okay, so just by eyeballing, if you see if your contraction is not good, it means the contractility is lower. Then comes your FS, that is your flexion shortening. Then is your EF, ejection flexion. And then is this velocity of circumferential fiber shortening. Basically, this is a very good parameter. In newborns also it can be used because it is independent of afterload. Your FS and EF and everything is load dependent. That how much is your preload, how much is the volume in the LV, okay, and how much is the afterload. That if your SVR, systemic vesicular resistance is high, okay, then that also can hamper your ventricle contraction. Okay, but I don't think so. We will be talking about that in this. Our main focus will be on 3 things: eyeballing, how to calculate FS, and then how to calculate ejection fraction by Simpson's method, that is EA. And then diastolic functions, commonly we can do it once after the lecture of PDA, you will see what is this EA ratio. These are basically the mitral valve Dopplers. you get two waves, E and A. Okay, so that is significant. Their measurement and values are significant in PA also, and in diastolic, it shows the diastolic dysfunction of LDL. And for systolic function of both, there is one thing which is psi index. I won't be talking about that because that is more complicated thing. Okay, so just for nowadays in hematology, for RV function, what we commonly use is CAPC. Okay, it can be very easily calculated. What is CAPC? In advance, that one lecture is there. I will talk about CAPC. So one is eyeballing, okay, but the only issue is it is a very new classification. It is very subjective. Okay, now very commonly what happens is I am a trained neonatal cardiologist. I haven't done any echo for a bigger babies or a adult baby. So if I put a probe on 8-year-old boy, okay, the heart rate is half the heart rate of the newborn. So first thing I perceive is the contractility is not good. It is not the contractility, is that the heart rate is so, for me it is a bradycardia. So my eyes are not tuned to that. My eyes are tuned to see the heart pumping at the rate of 120 or 140. So that's why it looks like that so your eyes need to get tuned to that. So that is very important. So that's why it's very subjective. Okay. Can you see, compare these both? Apical 4-chamber views. Okay. So anybody can comment on this? What is the difference between both?
The left side is screen, the LV contractility is normal, and LV contractility on the right side is very less contractility.
This one is pumping. You can see very nice. There the machines are very bad. And I put a color also, and you can see a significant TR jet out here. Isn't it? So it is RA-RV has failed, and there this contraction is very is normal. Clear? So if I talk about apical 4-chamber view first, so we calculate our, like there are two views for calculating EF, ejection fraction. One is apical 4-chamber view, one is 2-chamber view. Okay. Ideally, you should be doing it in both. In pediatric and adult, they do it in both. But in newborns, itself the reliability of EF is not good. Why it is not good? Because there is the shape of LV is not being, it gets modified and gets fixed over the time. Okay, so there are issues with the shape of the LV. So that's why again this parameter is not very well standardized in neonatology. EF, okay. So that's why we don't tend to do it in apical 2-chamber view. We tend to do it in apical 4-chamber view. But commonly it is not being used in newborns. We commonly use FS to calculate the contractility of the heart. But you have to do it. When we talk about it, it's being done by Simpson's method. The normal value is 45% to 75%. In machines, it is a very commonly, as soon as you will do your FS, fraction shortening, if it is 30%, automatically EF will come at 60%. Because normally EF is almost the double, 1.8 to 2.2 times your FS. But actual sense it does not happen. But your machines will give you this number. You should not be relying on those numbers, because in algorithm of the machine, it has been put like that. As soon as you calculate your FS, it will give you EF. As you calculate EF, it will give you FS. Okay. So, and then you have for fraction shortening, you have two views, parallel short axis and long axis view. And the normal value is 50% to 55%. Okay, so that FS, you do it, fraction shortening, you do it in M mode, in parallel long axis and short axis. Okay, and for EF, we do it in apical 4-chamber. So, parallel long axis view, everybody is well known. I should not be repeating it. This is how it happens. So, this is your parallel long axis view. You put an M mode, and that M mode line, like it should be almost vertical to the septum, one, and it should be crossing when your mitral valve flap opens and just hits it. It should capture your cavity, and just at the edge of your mitral valve. This is how you will get. So this is in diastole, this is in systole. So when it is in systole, your mitral valve comes into the picture and then it goes off in diastole because it moves away. It moves away from this time. So this is the exact view where you calculate your FS in passion long axis. So there in the machine only it has been fed, the fluid will be there. You calculate the diameter in diastole, you calculate the diameter in systole. Okay, so left ventricular end diastolic diameter minus left ventricular end systolic diameter divided by left ventricular end diastolic diameter into 100. That is what is your FS. But we need not calculate, the machine will calculate. Okay. This is what I have just explained you. Okay, in short axis, as sir already told, there are actual sweeps. Okay, there are sweeps in short axis view. So this is mitral valve view, fish mouth view. What happens if you put a probe? You have to move it down. Start with that Mercedes-Benz view. The next view is this. When you sweep down, it is mitral valve view, what we call as fish mouth view. Next comes the capillary muscle view. So this is your capillary muscle view. So this is the view in which you calculate your FS. And this is the last at apex, which is apex of this matter. Okay. So this is how again you do the same thing here. Okay. This is where your line should in capillary muscle view should calculate. And then you calculate it. So that is fraction shortening. In 3 terms, FS is 25 to 40%, term is almost the same. The range is 25% to 55%. But again, I told you it affected by afterload and preload. So it is load dependent parameter. So that's why it is becoming a big problem for us in neonatology. Especially today. So I'm doing a PhD and my topic for that is we are doing it with the speckle tracking because that again is load independent criteria parameter, and we are trying to see whether it gives some number to tell whether this is HSPD or not. Because to define HSPD there are a lot of parameters. It is not a single parameter. This is what I'm trying to see with speckle tracking. So again, this load is an issue, but this is what we have got for the present. But again, now the caveat is if your baby is in shock with high pulmonary hypertension, what happens in that? Your RA-RV gets dilated, isn't it? So your passion short axis view, the septum gets flat, or it has got paradoxical movement in your LV. It becomes like this. If that is the situation, your RVs are high and your septum is flat or invaginated in your LV, then it is not as reliable. You should not be doing FS in that. So this is by Simpson's method, apical fourth chamber view. So this is traditional apical fourth chamber view. This one. Okay. And this is the apical fourth chamber view. Fine. Why this video is not getting clear. Then you need, and so what there we were calculating the diameters. Here we are getting the volume of the chamber. So we get to do the area. So it is to be done at end diastole phase and end systole phase. Ideally, you should be having a ECG here. That is the ideal thing. But if you don't have it, then this is when your chamber is biggest with your mitral valve closed, and your chamber is smallest when your mitral valve are closed. To calculate these two areas like this, machine is you have to rotate, map the area with this thing. And then it gets calculated. So it is your left volume of LV in diastole minus volume in systole divided by volume in diastole into 100. This is how it will look. But as I have already explained, what are the issues with this? Okay, why? Because you get large error because of the shape of the LV in newborn, especially in the preterm. Okay, and this thing we have just discussed. So your rentable function y volume is being done. Okay. There is not a single, again, your VCF, your circumferential shortening is the one which gives you the afterload within assessment of the afterload. Or you can assess the afterload by speckle tracking or tissue doppler. That should mean, like suppose if you get a baby who is in shock, especially in the preterm baby, what happens initially, your SVR is high, physiologically high. So LV is not contracting. So that means it is not the defect of your myocardium of your LV, it is because your afterload is so high, your LV is getting weak to pump the blood against that high intensity. So these parameters will not give you that affected data or measurement. Is it because of myocardium of my LV or it is because of high afterload? The only thing it will give me that my function contractility is low. Okay, if I try to do the LVO, left ventricular output in that, it will be low. The only thing is, if your perfusions are bad, your invasive blood pressures are high, and your cardiac output is low. So that will give you indirect indication that your afterload is low. So that in that case, you need to start inodilator. No, you will need to start milrinone or glutamine. If you start dopamine in that baby, that will be bad. Got my point? So this is for diastolic functions of LV. So which is this view? Apical force number. So this is my color Doppler window. Where I put my color Doppler window? Mitral valve. So what I will do is I will put my pulse rate Doppler just below mitral valve in the LV here, and this is what I will get. So two waves I will get, E wave and A wave. Okay, this is my E wave. E wave is because of the passive flow of the blood from LA to LV. Because why it is passive? As soon as your mitral valve will open, by virtue of presence of volume of blood there, it will go down. So that is one way. Then my contraction will start. So that is the A wave. Then the blood flow from atria to ventricle by virtue of contraction. Okay, so the normal value in preterm it is 0.81 and in term it is 1.12, around 1 to 1.2.
Baby of dimple sample moklayu છે અને
The EA ratio is less than 0.6 or in term it is less than 0.7. It is suggestive of diastolic dysfunction. And you know why it happens? E wave.
Please share screen. Please share screen.
Thank you. Thanks for your it's an excellent talk and your representation of all co-leaders. So thanks, Moisa. Now we'll move on to the next talk of this PDA. Dr. Venkatesh is going to talk on that. Thank you.
I think so. Charging is on. Charge it. We'll do it from here. But it's fine. We'll do it from here. Thank you. I will just put the charge.
Before I start about this, activities, you all know that one of the important already is all season nutrient testing, right? So what how many of you use cocoa all want to see PD, right? Whenever this baby comes, especially the preterm baby, you want to see, right? So you all know, I think this group has echo in the unit, and you're all using the echo for the determination of pediatric sarcoidosis. All right. So we all know this parable. This is a very historical parable, and this parable clearly indicates that an elephant with blindness. We're all blind men. What does it indicate that we need to take as a comprehensive rather than taking one point to say that yes, this PDA is significant. Next slide, please. Yeah. Disclaimer. I am neither a radiologist nor a cardiologist. I'm just a newborn physician who has a passion about hemodynamics using bedside ultrasound as an extension to the physical exam. Very important. Never forget your basic MBBS. Read guide and basic MBBS. Very, very important where this is given paramount their importance. Correct? So this is an extension to the physical exam. When you talk about echocardiogram, don't go. The take home message here is not that you go and do the echocardiogram. It is to learn the physics behind it, the physiology behind it, and as the PS speaker said, actually, all what the mind doesn't know, the eyes cannot see. Make sure that you fill up the physiology in the mind that you can do this. Next slide, please. This is one really for a sick neonate. A sick neonate requires more attention time to the intensive care unit. Make it clear that you can really care using your wisdom and technology for my overall development. You are my friend indeed from birth, and I know that you constantly monitor me as a whole. I change constantly, very important. And you look at the change in sector right. Probe with the sterile probe with warmth and gentleness, and prove that you engage correlate clinically. See, again, engage clinically. So make sure that your gentleness is very, very important I'm very sad to say that when somebody comes from outside, the way they do the ultrasound and in-house fellow doing ultrasound entirely different. It's a parallel circulation. Nobody hand wash, no sterile taken, no weighing of sterile on, just come and do it. They are so hurried. The cardiologists to have a very cool heart, but we are not. So moment they come, the information should be there. They start shouting at it. By the time the normal figures become fewer. Yeah. So the object is what given by the echo parameters, PDA assessment and PDA management. I'm not going to talk about PDA management. How it is useful in managing that human significant inductor sources. So as you rightly see, that is the 3 legs spine what you see, one without 2 branches, and you see the red leg, what you see, that is third leg, that is the red leg. Okay, next step please. So why is this topic chosen? Always go to any conference, PDA, PPH, PDA, PPH. Even if you see after 10 years, if you talk about the same thing, and something new added, and then they repeat this topic. Every conference has this topic, you know, thousands of applications. Go and see that. Oh my God, PDA and neonatology, if you put PubMed, you get lots of, and you see there, everything is repeated. One or two things is said. It is the active form or passive form, something like that. Other than most of the literatures commenting on the same thing. Yet being debated amongst neonatologists, cardiologists, and surgeons regarding manual. Same concordance? No, not of this class. If you don't believe that, he doesn't believe that, surgeon people waited for the 9 accidents against something, no, these people require like all. That's how the thing is. And always you know that the 3 things we use. And wherever you go, what? And then comes actually the biomarkers. Nowadays, biomarkers, my God, I don't know what is the 28 feature biomarker level actually those things we do, correct? That peptide, this peptide. And people now they say that, hey, don't worry, you do peptide, you can't peptide, treat the baby. And they forget the baby. And maybe around 25%, 30%, oh, peptide is abnormal, I think we should treat it. So that is very important. I don't know anyway. More and more get a lot of countries. Actually, coordinate the mercy of treating physician, whether it is a cardiologist or a neonatologist. Next slide. We all know that don't go much into the detail. Circulation. The better trying to know that duct is present inside the uterus, duct is present outside the uterus. Duct present inside the uterus is always right to left, correct? That will get changed into bidirectional depending on the pressure because it has to get located before the system pressure increases, burner pressure becomes equated to system pressure. That's how you see what is called bidirectional. Of course, at the end of the story, the system pressure goes up and the pulmonary pressure comes down. That's how you'll find the left direction. This is very, very important in the management. Do I treat the baby with right direction? No. Do I treat baby with bidirectional? No. When suppose if you want to treat it left to right, it is very, very important take home message. And of course, there are a lot of things contributing for this. The antenatal steroids, gestation rate, mechanical ventilation. Of course, nowadays a lot of literature on low platelet count. And people just started doing, oh, it's low platelet count. Then do the platelet count in newborns, and platelet count is low. And you see a lot of babies with no PDA, low platelet count. Some PDA, low platelet increases. Then they thought, oh, we give platelet transfusion, we will not this pediatric, we want to neglect it. There are people who gave platelet also. Then somebody wrote, not the number, it is the function of the platelet, very important for the closure factors. And not even if you put it 40,000, and even if you make it 1.8 lakhs, but still actually PDA is significant because they said it is not the volume of the platelet. The functioning of the platelet, if the functioning of the platelet is not good, There is one of the contributing factors for the patency of this ductus arteriosus. Next slide, please. So I just start with a unit. A preterm unit born at 29 weeks of gestation required, as usual, the oxygen count started to increase with pink secretion in the endotracheal tube. The precordial active murmur, red gas metabolic acidosis. The heart rate was around 190 beats per minute. Low diastolic pressure. The dorsal space artery was well fed. It just takes around pulmonary edema. The sepsis was low. So it is a common scenario. I think you all know that this metabolic acidosis and the high requirement of parameters in the ventilator, they all go into patent ductus artery, which is significant. Next slide, please. So this is what exactly I want to tell you. This is how the clinics, we look at the tachycardia, we look at the white pulse pressure. So this is very important, white pulse pressure. We always look at what is systolic and diastolic. Remember, what we see is the diastolic, very low diastolic flow. But if it worsens even the systolic, remember that's what they say. You may say that systolic blood pressure is normal, diastolic is going up. That's what you see. But in the later part, if you don't manage these values, the systolic blood pressure also starts coming down. Another important thing here. Of course, some of the things what I mentioned my previous slide. So why some period? So three things more. If I want to worry, look at three areas. One area is, am I looking at the system, whole body. Then you look at the brain. Then you look at what is called as your lungs. So these are three important areas we look at. That means what I'm going to talk to you is, am I dealing with a baby hemodynamically significant mediate contributing for systemic undersaturation? Or am I seeing a baby with whenever undersaturation happens, definitely there will be more perfusion into the lungs. It's another thing. So these are the two important. Second thing, actually, the fourth fellow who is there, the top, also will get. So three areas where we are looking at hemodynamic significant mediate with respect to mortality and morbidity, three areas. Next slide, please. This is what exactly the echocardiography. You all know that. I don't want to go into details. You know, it's a focus on the bedside, and you can see that how the physiology it helps actually. It is not just you do once and go away. You can keep on doing. So those things actually will tell you that whether you are clinically correlation and also you manage these diseases, whether it's going to help with the assessment. Next slide. So these are the important planes, and you all know that most of the planes what we use the parasternal short axis, parasternal long axis, then we use subcostal views, and the fourth chamber views and five chamber views, and of course the subcostal views and modified subcostal views. So all things I don't want to repeat, already repeated. Next step. So what we are interested in ductal characteristics, pulmonary wall circulation, and systemic undersaturation. Okay. Next. So when I say ductal characteristics, you look at the ductal size. First thing is whether the duct is present or not, and what is the size of the shunt. The next is the direction of shunt. Of course, the gradient. So these are three important parameters when you see the characteristics. So presence of duct, and what is the duct diameter? What is the direction of shunt? Is it actually the right direction, bidirection, or left direction? That is very important for us to decide for the management. Of course, the gradient is also important. Next slide. So this is on short axis view. You can see that the 2D echo showing at the three legs side, and you can see this PDA here, the colored offer. Here, one should be very careful. This is very interesting on short axis view to know that ductus is present or not. But it's not a good view to measure the diameter of the duct. Because what's happening there in the short axis view, you may actually measure the left pulmonary artery also. So how do you know that you're measuring only the ductus arteriosus? For that, this view, what I have put actually the 2D echo first one, the below that, you can see that that is the pulmonary artery and the descending artery is the so this is a modified personal view. This is for ductal view, where this is the pulmonary artery, this is descending artery. So for the measurement of ductus, always the modified ductal view is important. It's called suprasternal view important. So that's how you can see that. This is actually a mode. When we put actually a mode or this color Doppler, you can know that there is a bidirectional. You can see it's a bidirectional. We are seeing both the red jet and blue jet. So it indicates the bidirectional. You can still wait before you hit the baby. You can still buy because I'm still actually at the level of bidirectional. Next slide, please. So there are different patterns. People they look at, oh, shall I take the Doppler and treat the baby? So if you see that Doppler, period, neonate, there's a lot of things. And they look at what are the different types. As soon as the baby is born, it should be completely regular. But the nature is wrong. As soon as the baby is born, we have done actually in the delivery room, we put the probe, immediately was done, but still it is difficult. We don't see the fetus cycle is so fast once you disconnect the placenta. Once you cut the umbilical cord, you'll find some amount of PPH interval where you'll find PPH interval, you get the pulmonary flow will be deeper. This is the right direction, downward. The upper one is the left direction. You see the deeper portion of the that is the pulmonary artery. Because pulmonary resistance is still there. That's the reason the flow is also, the down line is also too much. But as you move on, it starts growing. But you know the children, once they start growing, they start dancing also. So once you see the dancing phase, this is the growing phase. This is called as pulsatile. They start dancing. What do you mean by that? You mean that if I see a PDA, you see like this, the first one, I measure the systolic and diastolic part of it. If the systolic and diastolic part, if they are very close to each other, it is restricted PDA. That I'll show you next. If you see the difference between the systolic and diastolic, if it's too much, less than 50%, then it indicates that left direction is significant because it's pulsatile type of PDA. Then, of course, whether you manage, most of it is without management also start closing. So you may get closing. Of course, the closed ones you get only the pulmonary flow. This is how the pattern of there are 5 important patterns you see in ductus arteriosus. This you can appreciate as you keep doing everyday echo and see that what's the pattern, what's the pattern. Next slide. This is what exactly I was talking to you about restrictive and unrestricted. It's very important to know that in restrictive period, look at the important the systolic and diastolic. If they are very close to each other, it is always restrictive. They are away. That's what exactly I wanted to show you. But how the non-restrictive ductus arteriosus. Next slide. Yeah. So I told you 3 things. One is the blind. The other one you are worried about the lung, and the other important thing is the intestine. Now look at this assessment of pulmonary oversaturation. So what exactly you are very specific PDA lung should. So if you look at blood temperature, they only look at the lung, they look at the brain and the intestine. Here, if you look at what are the ways to assess the increased pulmonary circulation. When I say increased pulmonary circulation, what do you mean by that? If the circulation is more in the lung, which part of the heart is affected? More. Left heart. That's the reason I wrote left atrium and left ventricle. So if you see on echo, if the left atrium and left ventricle they are dilated, so think of that because pulmonary veins is bringing a lot of blood to the left atrium to the left. That's one part. When it is coming too much blood into the left atrium, what will happen to the left atrium volume? It increases. When the left atrium volume increases, what will be the ratio? It increases. So if it is more than 1.2, 1.4, left atrium becomes bigger than the LAO ratio. Most of the times, actually, you see the LA and LAO almost the same. If the left atrium starts increasing, the LAO ratio also starts increasing. Correct? But there are limitations. I don't want to go much into the detail of limitations. So what are other factors because left atrium? You know, there are a lot of other factors in the cardiac where exactly you see left atrium enlargement happens. Next important thing, talking about what is called as mitral invasion. Think that again, I'll repeat it. 70% of the blood. If you read Latin text, all Latin text. So 70% of blood from left atrium to left ventricle does not require any exercise. Just it goes. When it goes, just it goes. What will will happen to the E? Is it high or low? Because flexing is going there. That is the reason if I go and get my heart check, what will happen to my E? E is high. It's normal. Pediatric age of both E is normal because I am sleeping like God and everything is God. Only 30% of blood requires the contraction of the left atrium. That is the reason E is big. But in neonate, it doesn't happen. Why it doesn't happen? Because there is tachycardia. My heart is 70 beats per minute, but heart rate of baby is 140, 160. How do you expect this gastric function is good? If gastric function is not good, when gastric function is not good, how do you expect the E to be on the higher side? So we should be lower than that. Are you clear about that? So E by A, preterm baby is lower. How lower? Again, by 0.8, 0.8. So in an easy way, remember always 1 less than 1. But in adults, actually, it's pediatric. That's what I said here. What will happen actually? The first one is on, and what happens actually? The middle one, the yellow one, is E by A. I said 1.1. And again, if you see it normally, right? Yeah. So this is all E by A ratio has been taken. And this clearly, this is what plants might go off blood and you do consider of the The next important is electric clock flow. Electric clock flow, one diameter of the flow is important. That also discussed. I don't want to much into the detail. Next, so after knowing the lung force situation, we also interested in looking at systemic hypo and post vector aortic blood flow pattern. Important result. You take one. Right, to take vectors. So vectors you can do celiac, and you will do also the abdominal aorta.
They're coming. Distance. They're coming now. In any moment they will come. Sir, put the distance. Sir, they're coming. Without pass, please don't cut. Another 15 minutes. What is the Thank you.
So look at the superior look at the vectors, celiac tract, and the superior recording, in addition to the abdominal aorta, and of course, the right. Next slide. How you do? So it's across the view, that is across the sagittal view. Just a little bit to feet to the left, you get both the arteries. You can see the abdominal aorta. And what you see the muscle in the celiac tract, and next to that is your superior artery. The next thing you got which was for median portion, the transtemporal should you get actually the middle stable artery going towards the probe. That is the middle stable artery. And then you got superior cava. You can do both. You can do superior cava. You can do both the diameter and the probe. There's no need for one possible. Now I say that all is better to do, but you have to get the modified to and that's what we do. So you get, but it is almost the angle of installation very, very less. You can do. So there you can look at the diameter and so on, calculate. And what we are looking at is there any increase in systemic systolic flow or diastolic flow, or it is an absence of diastolic flow or reversal of diastolic flow. If you see reversal of diastolic flow, it's not good. If there is no diastolic flow, it's also not good. It is a normal flow, correct? So in all these results, look at resisting results. So look at the peak systolic velocity and diastolic. Very clear about that? It's all good. Next slide, please. So PDA endorphins, that's what I told you. These are the 3 important endorphins we'll look at. Next slide. So another important thing, you know that now you are satisfied that you are asking the surgeon, you have given already the paracetamol, metacin, hypogesic, repeated doses, but it is not improving. Now either the cardiologist will do filing or the surgeon is waiting for ligation. Now the ligation you do, very important. Most of the times, post ligation, they start decaying. It's called post ligation, very, very important. Where the echo will also. So currently, what is happening? They are giving more better left ventricle and post the stop. So here, Detection of shock, post surgery is very essential, and you can do it early and then fix also, and they all improve. So keep PDA, another important, you are so much happy to close, but be careful. If I say there is PDA, oh, close means the chapter is closed. Because if you have a baby yesterday, born 28 people, and this baby has anti-diagnosed transmission rate versus you that. Suppose the baby comes, diagnosis, and you see saturation, you see big black coming. Okay? And then you what do you think? Oh, it's a beta, we treat it. So it is paracetamol. All I do is then see that it's a group waiting for the improvement to start iteration and baby tax. First of all, 70, 60 saturation and baby tax because of the gut differentiation. Similarly, this is one important thing you can see that the pulmonary atresia baby, where you can see that the right atrial enlargement, very small right atrial right ventricle, and we want to keep this mediated. So what did they do? They did the stent. This is a lady they had things back, and this will be very well. The take-home message is, moment you say PDA doesn't mean that you are close, and you should always look for an essential connect. Okay, that is another important. Next slide, please. This is what we did a study. We were calling when I joined Manipur Hospital, where we used to call everything PDA present, yes, 3,000 rupees. Is it increasing? 3,000 rupees. We said actually medication given still it is present 3,000 rupees. We started calculating how much money daily for PDA evaluation. It's around 28 particles. It's only for PDA. Then we thought actually how to cut down. Cardiologist called for the sake of finishing beyond unless you know the anatomy, the 2D echo properly, but you cannot assess this also. But still, we wanted them to keep check that there is no cyanotic artery. Correct? Once it is ruled out, then remaining ultrasound we started doing the first. We could bring down from 100 rupees to 20 rupees. 80% is safe. It's published tests actually recently. And where you can see the baseline information here. So well, see the cost, how much you could bring it down. So this is another important study. But remember that it needs a lot of hard work. You have to stay in the unit, keep doing, and have the help of great cardiologists, especially late echo technicians. They are the best people, always available, and then you can learn quite a lot. That's very important. Next slide, please. So take home messages. We all know that the common modeling presence of figure does not mean close. Clinical assessment is the basic foundation before the use of technology. More and more hands-on training is essential in acquiring the depth of knowledge. Rule out gut patient before considering the closure. Knowing everything is a knowledge, but the wisdom lies in the fit. To me, the PDA is poverty in defining and assessing significant efforts. Thank you so much. Next slide. Yeah, this is my key. Book. If you are really interested in getting the book available, thank you so much.
Thanks for your excellent talking. Move on to next talk, Dr. Pooja, the consultant from Andhra Hospitals. She's going to talk on field.
Hello everyone. We'll move on to the next topic. I am asked to speak on PPHN, how functional echo helps in assessing PPHN. I'm Dr. Pooja, the consultant neonatologist from Andhra. And I also thank the organizers for giving me this opportunity. So we'll start. So what are we going to do in the next 30 to 40 minutes is we'll introduce ourselves to the topic. We'll see the pathophysiology, because unless we know the pathophysiology of PPHN, it's very difficult for us to manage PPHN. And we'll see how echo is going to help us in diagnosing and managing PPHN. And management will just rush through, and we'll finally sum up. So see, all neonatologists will be familiar with this topic of PPHN. So that's the reason I have written it's very familiar, and I would like to call it as a very fascinating diagnosis. Because as we can see, every other disease in newborn can finally lead to PPHN, and we need this PPHN as a Superman. And we find it difficult to treat this Superman at the end of the day. Any disease, you take it to your meconium, RDS, hypoxia, hypothermia, pneumonia, if not properly managed, can finally lead to PPHN. So, PPHN is nothing but a syndrome of circulatory maladaptation network, and the occurrence is about 1 to 2% per 1,000 live births. All babies with PPHN are either term or near term, but even 2% of preterm babies, you can have PAH. So the mortality is around 5 to 10%. So as I said, unless we know the pathophysiology, it's difficult for us to manage. So always PPHN, it has to be a physiology-based approach. These theory slides will then rush through. We have primary and secondary. Primary accounts for 10 to 20%, where there is abnormal remodeling of the pulmonary vasculature. And secondary PPHN is basically maladaptation and underdevelopment of the pulmonary vasculature.
How he created dongle?
This also will skip. This is all theory part. What is the causes of secondary PPHN acquired and will skip. So as I said, we all should know the pathophysiology of PPHN. Don't worry about this slide. Next slide. See what happens. You have hypoxia, you have ischemia, you have got placental insufficiency. At the end of the day, what you have is increased pulmonary vascular resistance. So this one term we all should get into our brain. So what happens when there is increased pulmonary vascular resistance? Obviously, there will be decreased pulmonary blood flow. And once we have decreased pulmonary blood flow, there will be decreased return of oxygenated blood to the left heart. And finally, there will be decreased blood to the end organ, which again lead to decreased end organ perfusion, tissue hypoxia and acidosis. Which both are hypoxia and acidosis again are both potent vasoconstrictors. So they finally again will cause increased pulmonary vascular resistance. So then a vicious cycle is set in. So just remember, in any baby with PPHN, we have increased pulmonary vascular resistance. The cause can be multifactorial. So we need to properly treat hypoxia and acidosis. And another important thing we often miss in managing PPHN is we need to know the cardiac function while we assess any baby with PPHN. So what happens, as I said, when there is increased pulmonary vascular resistance, obviously your right heart gets affected. There can be right heart dilatation because of the increased afterload. It can be right heart hypertrophy also, and there will be right to left shunt, resulting in decreased pulmonary blood flow. And meanwhile, your right heart dilatation, what happens is there will be septal deviation. So this septal deviation again can cause decreased left ventricular filling. So there is decreased preload, and because of the ventricular interdependence, again you can have left ventricular dysfunction also, which again will cause decreased systemic blood flow and decreased end organ perfusion, and again which again can lead to increased pulmonary vascular resistance. So always assessing any baby with PPHN, just remember to assess the cardiac function also. Thanks. So as I have said, these are the hemodynamics one should always keep in our brain, because unless we know what we should look for, we don't be seeing in the echo. So we need to have a measure of the increased pulmonary vascular resistance, which is technically not feasible without echocardiograph. So what we will do is we'll measure the pulmonary arterial pressure. And we have to measure both right and left ventricular function. Again, if right ventricular fails, we can have pulmonary venous hypertension. These are the pathophysiology, hemodynamics involved with PPHN. So the basics, so two formula which we have to remember. One is the Ohm's law, which pressure is flow into resistance. So as I have said, we can't measure pulmonary vascular resistance. So what we measure is the pulmonary arterial pressure, which is related to the flow into the vessel and the resistance. So remember, your pulmonary arterial pressure is not equal to the pulmonary vascular resistance. And next one is the Bernoulli's equations, where pressure is 4 into the velocity square. Because this formula we need when we calculate our pulmonary arterial pressures. So we get into the topic proper with this background. So what are the things when you look for when you do the functional echo and we are suspecting PPHN for the patient? So first is the visual assessment. Then we will calculate the pulmonary arterial pressure using our triage jet, that is the tricuspid regurgitation jet. And if the baby has PDA, assessing your pulmonary arterial pressure becomes very useful with the shunt velocity. Then other component is pulmonary artery acceleration time or the time to peak velocity. And time to peak velocity is RVAT ratio. And next, the last one will be your septal morphology. How is your septum moving? Next. So this already discussed by Dr. Mohit and all the speakers who spoke just before me. So on visual inspection, first video. So this video itself we can see. So first video, the contractility appears to be good, but there appears to be right atrial and right ventricular dilatation. So the contractility appears to be good. But in the second video, there appears to be a decreased contractility of the left half. So how this has already been mentioned, this is observer dependent. For someone it may appear to be normal and some it appears to be abnormal. This we get with lot of training and lot of the number of echoes we daily practice. So the first one is the visual assessment, which is the So what I want to highlight is your interventricular septum has to be straight, because who are new to this, they often end up doing the subcostal views and assessing the ventricular function in the subcostal views. So proper apical four-chamber view, your interventricular septum should be straight. I mean, you have to get it. You have to get exactly perpendicular in the window. Next slide. So once we have assessed with our eyeball whether there is right heart dilatation, then we will calculate the pulmonary arterial pressure. So how we do that? We calculate the TR jet velocity, which is again done in the apical four-chamber view. Apical four-chamber view positions again we are not doing, that is basic echo. Remember, you get your IDS straight in the midline of the window. Then calculate your right ventricular systolic pressure using the formula 4D square, which we have to add up our right atrial pressures also, which we take roughly 3 to 5 millimeters of mercury in the newborn. So this view, why I have put it is, this is not a proper view for measuring the TRJ, because the heart is inclined, still the heart is in the sleeping position. As I have said, your interventricular septum has. We can see a TRJ over here. If you put a Doppler over there, my sampling gauge should be exactly parallel, or we can allow up to an angle of 20 degrees, not beyond that. So always try to get your IDS interventricular septum straight. Okay, so now the second picture we can see my Doppler angle I have put, and I have calculated my TRJ. This is my TRJ. So, look for the TRJ. TRJ is always a beautiful envelope. Okay, we have to get a beautiful envelope, then only our measurement is going to be right. So once we calculate the velocity, get your cursor over here and to the tip of the velocity. So it is 4V square, and with, add your right atrial pressure. So Nietzsche, I have done the calculation. So you are for this baby, for this particular baby, your right ventricular systolic pressure is coming around 64.5. So measurement of TRJ, remember to get a proper apical four-chamber view and get your Doppler angle right. It has to be parallel or accept a minimum of 20-degree inclination. Next slide. As I said, the pitfalls will be for the beginners getting your four-chamber and remember you have to use a continuous Doppler while measuring your TRJ, not pulse Doppler. And your angle of inclination should be less than 20 degrees. And always calculate only when you have a proper envelope, set envelope. So in that view, which I had showed earlier, when my heart was still in the sleeping position, when I try to calculate, even though the Doppler angle seems to be normal, when I try to calculate, previous slide, when I try to calculate the TRJ, my jet envelope was not correct. So even though if I calculate here, we get a wrong measurement of the pulmonary arterial pressures. So try to remember these things. Get your four-chamber right. Get a proper envelope. Angle of inclination should be completely parallel or less than 20 degrees. Then only calculate your pulmonary arterial pressures. Next slide. So the most common thing is for us, it's like you have PAH. You need to have a TRJ. No, does the absent TRJ rule out PTH? It's not always like that. So there need not be a TRJ always for us to diagnose PTH. So when we get a TRJ, always confirm this TRJ in another view also, which is the right ventricular inflow view. I hope all of you will be clear, will be knowing about that view. Next slide. See, once you are into the flat view means your marker is onto the right shoulder. Your probe marker is onto the right shoulder, longitudinal view. Once you get that view, just tilt your probe towards the liver. When you tilt your see, this is the probe, and my marker is this side. Once I get my flat view, what I do is I tilt my probe towards the liver. So when I tilt my probe towards the liver, I will be opening the right atrium and the right ventricle. See, this baby does not have a TRJ, so the TRJ is not visible. So this is the RV inflow view. So in your class view, just tilt your probe towards the liver. You will have an RV inflow view where again you can get a TRJ. There again you can put the Doppler, and because that Doppler angle will be always parallel. So then you can get here. Because the baby is not having a proper TR, we are not getting a proper envelope. But if the baby is having significant TRJ, here also we get a beautiful envelope, and we can calculate our pulmonary arterial pressure even from this view. So if you are not getting a TRJ, proper angle is effectively, because once some babies might be ventilated because of PTH or due to any other cause, and when your lungs are inflated, very difficult to get a proper apical four-chamber. Then this view becomes very handy for us. So always try to learn this view also.
Okay.
Right ventricular inflow view.
Sure. We have to change the laptop?
Yes, we need to go.
Oh, internet is there.
Next slide. Once we are done with the TRJ, then another parameter which helps us in assessing the PTH is the ductal shunt. All babies need not be having a PDA, but for those babies for whom we have PDA, we can even calculate pulmonary arterial pressure from the ductal shunt also. So if PDA is present, first see with the left to right or a right to right shunt. Whenever we have PPH, it's always a right to left or a bidirectional shunt. But remember again, a right to left shunt always rule out some cyanotic congenital heart disease. Then only think of PPH. That is always been highlighted by previous speakers. Again, important things are measure the velocity in the ductal view, and then go for the color Doppler. And here we always go for a pulse wave Doppler. So these are the settings we use. Use the ductal view, put the color Doppler in the sampling rate in the color Doppler, and then go for the pulse wave Doppler. So just see here, for that baby, it's a red color. That means red means Doppler basis everyone will be knowing. Red is towards the probe. So that means the baby is having a left to right shunt. So left to right shunt means your systemic pressures are higher than your pulmonary pressure. So you can rule out your pulmonary arterial hypertension. So when you suspect PPHN, you have either you have a bidirectional shunt like this, or you have a plain right to left shunt. So here it's bidirectional. Now we'll get confused whether to take which way. Is it a left to right or a bidirectional? Then calculate the how much component is your left to right shunt. If this component is more than 30%, then you take it as right to left shunt. How do you calculate that? You take the time from the beginning of the cardiac cycle to the end, and the timing of the systolic timing. So if this is less than 30%, then that is left to right shunt. If it is more than 30%, you take it as right to left shunt. And how do you calculate? Again, you measure the velocity, the shunt velocity. Keep your marker, measure the velocity 4V square. Otherwise, automatically you will get a pressure gradient as you get a DRJ. So get the velocity 4V square and you add that to your systolic blood pressure. The baby will be being monitored for the blood pressure, either invasive or non-invasive. So add your pressure gradient with your systolic blood pressure, or you can calculate it with the velocity itself. Hope I am clear with that. So see whether it's a left to right shunt. If left to right shunt means PPHN, we may not worry. If it's a right to left shunt, see if it's a bidirectional or a pure right to left shunt. Pure right to left shunt, we don't be having any dilemma. We can calculate the velocity, go for 4V square and add to your systolic blood pressure. If it's a bidirectional shunt, calculate how much of the component is your systolic component is your right to left shunt. If it is more than 30%, then take it as a right to left shunt, and you can consider you can add it to your systolic blood pressure. Okay, systemic blood pressure. So another useful component which helps us to assess and to see if there is a PPHN is flow across your patent foramen ovale. Again, across PFO, if it is a right to left shunt, please rule out some cyanotic congenital heart disease. This all the speakers have already highlighted, but again, any right to left shunt across PFO, rule out cyanotic congenital heart disease. In PPHN also, we can get right to left shunt or a bidirectional shunt across the PFO. So the same baby, this image shows a left to right shunt, the first one, whereas the second image shows a right to left shunt. So the baby was having a bidirectional shunt across the PFO. So that's the reason I have used the terminology like it's a non-specific. We just have get a clue whether the baby is having PPHN or not. Next slide. So this is the bidirectional Doppler waveform which we get. Next slide. So once we know there is a component of PAH and we try to measure your pulmonary arterial pressure with a PR velocity or with your PDA shunt. So how do you grade that? If it's less than 35, we take it as normal, and if it's 35 to 45, we take it as mild. If it's 45 to 60, we take it as moderate, and if it's more than 60, we take it as severe PAH. So we have completed our TRZ velocity. We know now how to calculate using our PDA shunt velocity, and we will get a clue by looking at our PFO, whether it's a right to left or a left to right. Now what? Having high peaks, we not be getting the proper TRZ. Even in the RV inflow, we will not be getting the proper TRZ. So what are the other measures which we can rely for calculating? We can't calculate pulmonary arterial pressures with these views, but at least we can know whether there is PAH or not. So this is the pulmonary artery acceleration time, or the time to peak velocity. Time to peak velocity is like this is done in the short axis view. You keep your Doppler gauge just below the pulmonary wall, so that you can get the pulmonary arterial flow. So whatever the tracing we get is the pulmonary arterial flow. So this time to peak velocity is we take the time taken for the jet from the onset to its peak. The two lines which I am shown here. So from the onset to the peak of the jet, that is the time to peak velocity. Normally, it will be somewhere around 100 milliseconds. But if it's less than 90 milliseconds, there might be some pH component for that baby. And if it's less than 40 milliseconds, definitely there can be severe pH. So when that time gets narrow, interval gets narrower, it means the baby is going for severe pH. So that waveform will not be laminar jet. There won't be an envelope anymore. It will become triangle shape. Next slide. Okay, I'll show the triangle shape in the coming slide. So the 6th parameter is the TPV with the RVET ratio. What is RVET? Right ventricular ejection time. So how do you calculate it? Main view, short axis view, Doppler gauge just below the pulmonary valve. You get the good pulmonary flow velocity. You calculate from time to start to the end. So that is the RVET. So you calculate this ratio. This is the least accurate measure of all the things we have discussed. It will be less than anything less than 0.34 is abnormal. So normally it will be more than 0.3. If you want to quantify it, 0.3 to 0.2 is moderate. Less than 0.2 will be severe. I have done this for that baby. See, I have shown here. This I have taken from the textbook images. See, it becomes almost like a triangle. So your jet will be like this. It won't be anymore a laminar flow, and you can have a mixed systolic notch over here. That means your pulmonary flow becomes a W-shaped flow. So these are other indirect measures if the baby is having PPH or not. See, for this baby, see, it's almost like a triangle shape. This baby is having PA. It's almost a triangle shape, and we can suspect a mid-systolic node, but I admit this is not a very good picture to show that. But definitely there is a triangle shape flow across the in the pulmonary artery. Next. So with all these parameters, your T-average velocity, your flow across the PD, your flow across the PFO, your RV, your time to peak velocity, and TPV to RVET. Once we are done with that, another thing which can help us is the intraventricular septal motion. How will we get this view? Short axis view. So everyone knows short axis view. Suppose this is the marker. Once we are in the short axis view, tilt the probe towards the keep the probe there itself and tilt towards the apex. Then you will be opening up the mitral valve first and then the papillary muscle. So just check for your septum at the level of the papillary muscle. So these are the papillary muscles. So you can see, you can appreciate that the septum is like your septum is straight. It's almost like a D-shaped left ventricle. Okay. Next. So what do you expect? The normal curvature is almost like a circle. See, those two are the papillary muscles, almost like a round configuration. When you have a flat septum, you can estimate your pressures are moderate. And when you have a crescentic septum, that means the septum is going into the left ventricle because of the significant right ventricular pressure. It's like a crescent shaped left ventricle. So there you can suspect severe pulmonary arterial hypertension. When quantification is there, we won't be going into that. So way to get your view, short axis view, tilt towards the apex, just above the papillary muscles. We need to visualize the papillary muscles properly, whether it's O-shaped, D-shaped or crescent shaped. Next. So these are the basic parameters for assessing PPH. But as I have said earlier, in the pathophysiology, any baby with PPH can have a compromised cardiac function. Either it can be right ventricular or left ventricle. So always try to look your cardiac functions also while assessing a baby with PPH. So this Mohit sir have already dealt in detail. I'll just rush through. So what are your functions for your right ventricle? Systolic function, visual inspection, that is the eyeball effect. Then your Tapsi sir again will be dealing. And this I will tell, right ventricular systolic with diastolic ratio. and fractional area change, and RVO is already dealt in detail, so that we won't discuss. And what is the parameter for diastolic dysfunction? It is the E to A ratio. Next slide. So this is the eyeball effect. See, we can see we can appreciate that how contractility is good. So next. So Tapsi, cervical, tricuspid, annular, plane, systolic exertion. Usually, remember it is 8 to 10, 8 to 12, anything less than 4 is significant. What do you do is, you put your M mode along the lateral annulus. So once you get your apical four chamber view, put an M mode along the lateral annulus, you will get a jet. So this is the measurement of Tapsi. So this will take a class. So I just rush it. So anything less than 4 indicates there is severe dysfunction. So the third parameter, what I have told is the right ventricular systolic by diastolic ratio. So there you have TRJ, get your TRJ, then calculate what is the systolic divided by diastolic ratio. Systolic is your TRJ interval. TRJ interval is systolic, and diastolic is the interval between the two systolic. So that if SB ratio is more than 1.3, remember there is a global right ventricular dysfunction. So fractional area change again discussed. So get your apical four chamber view in systole, then in diastole. Remember you need to get the full ventricle because this will be a manual tracing of the endocardium. We'll be showing in the workshop how to do that. So once we get the apical four chamber view and we trace it, it will be a manual tracing of the endocardium. So try to get the chambers right. So this we know the formula and we even know how to calculate. I'll skip. So in the diastolic also, apical four chamber view, E and A wave. E wave is due to the passive filling of the ventricle, whereas A is due to the contraction. So usually it has to be equal. Both the waves have to be equal. If E wave is less, then you suspect mild. When it is more, that means your A wave is becoming high. That means more than 1.5, there is a moderate dysfunction. More than 2, the severe dysfunction. Next. So left ventricular function, systolic again, visual, fractional shortening. We as neonatologists always rely on fractional shortening. We don't go into EF for that much. And then myocardial performance index, and then LU. And for diastolic function, it is again E to A ratio and your pulmonary vein Doppler. So fractional shortening, everyone should be knowing this fractional, how to do this fractional shortening. We can do in 2 views, plus or the short axis view, long axis view or the short axis view. So once we get the long axis view, what you do is you put the M mode. That M mode has to be at the level where your mitral leaflets end. And in fact, in the image also, we should not accept even that much inclination. It has to be horizontal to the window. So it is very, as sir has already said, it's very preload and afterload dependent, and the normal is 25 to 40%. Ejection fraction, just remember you are doing the Q. Whatever for fraction shortening, the same formula, you just do the Q. So normal is somewhere more than 50. So anything less than 30, we consider as 30 dysfunction, severe dysfunction. Again, LVO del. So not dealing. Remember the chambers where you have to get that aortic VTL, apical four chamber view, and aortic diameter. Again in the long axis view, where you are at the hinge of the. So there will be a lot of confusion whether way to measure your aortic diameter. That will be showing in the workshop. So it has to be at the hinge of your aortic valve. Next. So this myocardial performance index is a bit difficult to understand. I'll just simplify it. Once we are in the apical four chamber view, we can see the Doppler. We can do. I always do it separately because I find it very difficult to get a Doppler of both aorta and mitral valve at the same instant. So I do it separately. I get first I get the aortic VTL, and then I put my Doppler at the mitral valve and get my E and A wave. So just remember that B and A, and look at the formula. A minus B by B is your myocardial performance index. So your A is the interval between the two waveforms. I'm just simplifying it. Your interval between the two waveforms is your A, and B is the just your iotic VTA, that time. So your myocardial performance index is A minus B by B. So its normal is 0.25 to 0.38. It is independent of your heart rate and blood pressure. This we'll see when you're in the workshop also. Next. So diastolic dysfunction. So those are the E waves and A waves. Normal is 1:1. Anything more than 2 indicates severe dysfunction. So another thing which can help in whether there is diastolic dysfunction is the pulmonary vein Doppler. Pulmonary vein Doppler, you have got two waveforms. If this velocity is less than 0.6, then that is significant. Then again there is you have compromised diastolic function. Next. So that is what. So you first you clinically you have to suspect PAH. Once you suspect, get your echo, do your bedside echo, get your TRJ not visible because of ventilation or high pressures or anything. Try to get RV interview. There also TRJ not visible and the baby has PDA. Calculate your pulmonary pressure using the shunt PDA shunt. Still, even that is not possible when you are suspecting your PAH. I have told you indirect measures of time to peak velocity and TPV is to RVT ratio. And then your IV sector, interventricular sector. So then, remember, we need to see minimum of effect, left ventricular function and right ventricular function task. So, because our management is always pathophysiology based, so management is always pathophysiology based. Avoid hypoxemia and hyperoxia. Even hyperoxia is not good. It is PAH, get your 100% damage. That is not good because hyperoxia can cause free radical damage and even nitric oxide won't flow properly. So the basics in management is
ಎಲ್ಲ ಕ್ಯಾಪ್ಚರ್ ಇನ್ಪುಟ್ ಇರೋಲ್ಲ ಸರ್ ಕ್ಯಾಮ್ರಾದವ್ರು ಕ್ಯಾಪ್ಚರ್ ಕಾರ್ಡ್ ಕೊಟ್ಟಿಲ್ಲ ಇಲ್ಲಿ ಇನ್ಪುಟ್ ಕ್ಯಾಪ್ಚರ್ ಕಾರ್ಡ್
what is an oscillator and how the pressure is regulated, what is the dose and
ಫ್ಲಕ್ಚುಯೇಟ್ ಆಗ್ತಾ ಇತ್ತು ಇಲ್ಲಿ ಎಲ್ಲ LED ಬೋಲು ಅರ್ಧ ಆಫ್ ಆಗಿ ಅರ್ಧ ಅಂತ ಎಲ್ಲ ಒಂದೇ ಕಡೆ ಪವರ್ ತಗೊಂಡಿರೋದು ಇವಾಗೇನಿಲ್ಲ ಅವಾಗಲೇ ಒಂದು 2 ಟೈಮ್ಸ್ ಆಯ್ತು ಅಷ್ಟೇ ಇವಾಗ ರನ್ನಿಂಗ್ ಅಲ್ಲಿ
always try to get all the components what we have discussed so that it will help us
presentation ಬೇರೆ ಯಾರು ರನ್ ಮಾಡ್ತಾರೆ ಇಲ್ಲ ಅದಲ್ಲ
be able to know why the baby is not responding.
ಕೀ ಜೊತೆ ಪೆನ್ ಡ್ರೈವ್ ಇತ್ತಲ್ಲ ಅದು
ಇಲ್ಲಿದೆ
So how this functional echo has done, we have already discussed primary diagnosis of PAH.
ಇಲ್ಲಿದೆ ಸಿಸ್ಟಮ್ ಅಲ್ಲಿ ಇದೆ
Cyanotic conventional heart disease before labeling it as only PPHN, and it helps in choice of the inotrope and it helps the monitoring the progress.
ಇದು ತೆಗಿರಿ ಸರ್ ಇವಾಗ ಇದ್ರದ್ದು ಸ್ಕ್ರೀನ್ ಕೊಡ್ಬೇಕಾ ಲೈವ್ ಯಾವುದು ಇದ್ರಲ್ಲಿ ಲೈವ್ ಕೊಡೋದು ಕರೆಂಟ್ ಹೊಡಿತದೆ ಎಲ್ಲ ಬೇಯಿಸ್ಬಿಟ್ಟಿದ್ದೀರಾ ಇವಾಗ ನೋಡಿ ಆ ಕ್ಯಾಮ್ರಾ ಇನ್ನು ನಮ್ಗೆ ಇಲ್ಲಿ ಬರುತ್ತೆ ಈ ತರ ಇಲ್ಲಿರೋ ಕವರ್ ಮಾಡ್ತಾರೆ ಅವ್ರು ಯಾರು ನಮ್ಗೆ ರೆಸ್ಪಾಂಡ್ ಮಾಡ್ತಾ ಇಲ್ಲ ಸ್ಲೈಡ್ಸ್ ಪೆನ್ ಡ್ರೈವ್ ಇದ್ರೆ ಹೌದಾ ಯಾರ್ದು ಅಂತ ಹೇಳಿ ಇಲ್ಲಿ ಒಬ್ರು ಇನ್ಚಾರ್ಜ್ ಬರ್ತಾರೆ ಇದಾರೆ ಲೇಡಿ ಇದಾರೆ ಬರ್ತಾರೆ ಅವ್ರ ಹತ್ರ ಹೇಳಿದ್ರೆ ಹಾಕ್ಕೊಡ್ತಾರೆ ಇದು ಇಲ್ಲಿ ಬಂದಿದೆ ಅದೇನು ಮಾಡಕ್ ಹೋಗ್ಬೇಡಿ ಬಂದಿದೆ ಇದು ಹೋಸ್ಟ್ ಬರ್ಬೇಕಲ್ಲಿ ಹೋಸ್ಟ್ ಬಂದ್ರೇನೆ ನಾವು ಅಲ್ಲಿ ಮಾಡೋದಕ್ಕಾಗೋದು. ಇದು ನಮ್ಮ ಕ್ಯಾಮ್ರಾದಲ್ಲಿ ಇದೆ ಅಲ್ವಾ, ಕ್ಯಾಮ್ರಾ ಇನ್ನು ಆಫ್ ಮಾಡಿದ್ದಾರೆ. ಇವಾಗ ಯಾರಿದ್ದಾರೆ? ಇವಾಗೆಲ್ಲ ಲಂಚ್ ಹೋದ್ರಲ್ಲ, ಅದಕ್ಕೆ ಆಫ್ ಮಾಡಿದ್ದಾರೆ. ಅವರೆಲ್ಲ ಹೋಗ್ಬಿಟ್ರಲ್ಲ. ಬ್ರೋ ಕ್ಯಾಮ್ರಾ ಆನ್ ಮಾಡ್ತೀರಾ? ಕ್ಯಾಮ್ರಾ ಆನ್ ಮಾಡ್ತೀರಾ? ಬರುತ್ತಾ? ಇದೆ.
ಇದಿಷ್ಟೇ ಸರ್, ಇಂಡಿಯನ್ ಬರಬೇಕು. ಇಂಡಿಯನ್ ಬರೋದಿಲ್ಲ. ಇಲ್ಲಿ ಪಿಕ್ಚರ್ ಬಂದ್ರೆ
ಹಿಂಗೆ ಪಿಕ್ಚರ್
ಊಟ ಮಾಡ್ಕೊಂಡ್ ಬರ್ತೀನಿ.
ಓಕೆ.
ನೀವು ಊಟ ಆಯ್ತಾ?
ಸರ್ ನಮ್ದಿನ ಲೇಟ್ ಆಗುತ್ತೆ. ಪಾರ್ಸಲ್ ತರಿಸ್ಬಿಟ್ಟಿದ್ದೀರಾ? ಅದು ಮಾಡ್ತಾರೆ ಒಳಗಡೆ ಎಲ್ಲ ಒಟ್ಟಿಯಲ್ಲಿ
ಎಲ್ಲರೂ ಮನೆ ತಗೊಂಡ್ ಹೋಗ್ಬಿಡ್ರಿ.
ಸರಿ ಸರ್.
ಪ್ರೆಸೆಂಟೇಷನ್ ಸಾಕಾಗ್ಬಿಡುತ್ತೆ. ಸರಿ, ಇದು ನೀವು ಬರ್ತಾಯಿದೆ ಅಂತ ಹೇಳ್ತೀವಿ.
ಹೌದು.
ಕ್ಯಾಮ್ರಾ ಆನ್ ಮಾಡಿದ್ರೆ ನಿಮ್ಗೆ ಬರ್ತಾಯಿದೆ ಇಲ್ಲ.
ಹೌದು.
ಅದಾದ್ಮೇಲೆ ನೀವು PPT ಶೇರ್ ಮಾಡ್ಬೋದು. ಲೈವ್ ಬರ್ಬೇಕು.
ನನ್ PPT ಲೈವ್ ಬರ್ಬೇಕಾ? ಇವಾಗ ನೋಡಿ, ಅಲ್ಲಿರೋ PPT ಇದು. ನಾನ್ ಲೈವ್ ಕೊಡಂಗಿಲ್ಲ. ಹೋಸ್ಟ್ ಅವ್ರ PPT ಶೇರ್ ಮಾಡ್ಬೇಕು.
ಮತ್ತೆ ಇವಾಗ ಹೋಸ್ಟ್ ಯಾರು ಬೇಕು?
ಹೋಸ್ಟ್ ನಾವಲ್ಲ, ನಾವು ಜಸ್ಟ್ ವ್ಯೂವರ್ಸ್ ಅಷ್ಟೇನೆ.
ಅದು ನಾನು ಏನು ಮಾಡಕ್ಕಲ್ಲ, ನೀವು ಏನು ಮಾಡಕ್ಕಲ್ಲ. ಯಾಕಂದ್ರೆ ಹೋಸ್ಟ್ ಯಾರು ಅವ್ರು ನಡೆಸಬೇಕು. ನೀವು ಮೀಟಿಂಗ್ ಲಾಗಿನ್ ಆಗ್ತಾ ಇದ್ರೆ
ಅಷ್ಟೇ. ಇಲ್ಲಿ ಏನು ಪ್ರಾಬ್ಲಮ್ ಇದಿಲ್ಲ. ಇಂಟರ್ನೆಟ್ ಪ್ರಾಬ್ಲಮ್ ಇತ್ತು, ಅದಕ್ಕೆ ಆಗ್ತಾ ಇರ್ಲಿಲ್ಲ ಅಷ್ಟೇ. ಇವಾಗ ಆಗ್ತೈತೆ.
ನಾನು ಕ್ಯಾಮ್ರಾ ಬರ್ತಾ ಇಲ್ಲ ಅಂತ ಹೇಳ್ತಿದ್ದೀನಲ್ಲ, ನಾನು ಅದಕ್ಕೆ ಟೆನ್ಷನ್ ಆಗ್ತಾ
ಇಲ್ಲ. ಅದೆಲ್ಲ ಏನು
PPT ಶೇರ್ ಆಗ್ತಿಲ್ಲ ಅಂದ್ರೆ ಹೋಸ್ಟ್ ಅವ್ರಿಗೂ.
ಹೌದು. ಬಂದಿದೆ, ಆಡಿಯೋನು ಇದೆ.
ಅದು ಮಿನಿಮೈಸ್ ಮಾಡ್ಬಿಡ್ರಿ.
We'll just start with scenarios. So this is giving you an
Zoom is on.
and how it will help you. So even though we know the normal parameters, why they are not helping us and how they will help us. So this is a term baby.
ಗೊತ್ತಿಲ್ಲ ಯಾರು ಅಂತ ಹೇಳ್ಬಿಟ್ಟು Zoom ಕನೆಕ್ಟ್ ಮಾಡಿ ಇಟ್ಟಿದ್ದೀನಿ. ಬಂದೆ.
On speaker, then on ventilator, dimensional with speaker. Echo was done. Showed moderate PPSN. Started on regional, signal on. So DIT was 28, sleep of 6, effort of 100%, and this was the pH. You can see it is acidotic, isn't it? Acidotic pH. That part is 8, base that is 19. OI is 28, and this is the blood pressure. Blood pressure are okay. This is the
ವರ್ಚುವಲ್ ಎಲ್ಲ ಇದ್ರಲ್ಲಿ ಬರುತ್ತೆ ತಲೆಗೆ. ಬಂದೆ.
This is the one with IBC and all that. These are the vital and very high dimensional ventilatory parameters. Okay. So the issues, what are the issues in this? What is the issue? And hypotension is an issue. So what we want to do?
First increase the oxygenation by the increasing the mass.
Okay, so there was the bad PPHN. What need to in functional echo? This is what we need to do. Isn't it? What to see that what is the severity of pulmonary hypertension? How are the RV functions? And afterload to the RV is your pulmonary pressure, isn't it? You have to assess that. You have to decrease to improve your RV functions. Preload, and it is again I have already discussed preload to LALV. Then again you have to assess LV functions. You have to assess LV afterload. Okay, so this was an echo. Can you, anybody can just describe which view and what is happening in this heart? RARB is dilated. Yes. So you can see this is RARB is dilated and contraction is low. Both is decreased on RV and LV. Both contractions are low. And this is the TR-jet estimation. But if your RV is failed, then TR-jet estimations are not reliable. Okay. So estimated pressure from this is 50 plus 56. Okay. So LV functions, okay, we need to do by fraction shortening. This we have already discussed. And then LVO we have already discussed. So this was the findings. Blood pressure 52 by 32 38. LVO is 132. It is normal or decreased. We have discussed that in last lecture. So it is on the lower side, isn't it? FS is 39% normal, normal, isn't it? CFT is prolonged, and pH you can see again is acidotic. So the issues after knowing the functional echofinding. Oxygenation is an issue because of pulmonary hypertension. RV dysfunction is there, so TR-jet is not reliable. Blood pressures, okay, but they are not reliable, even though the number, if you see 38 mean, is okay. But clinically, the baby is in low cardiac output state. Why? Because there is LV dysfunction and there may be increase afterload after. Because as we discussed, SVR may be high. So these are the issues. So it clearly tells me that whatever numbers, vitals I am getting, and whatever functional echo normal parameters I am getting is not at all giving me a very good picture of what is happening to this baby. Whatever we have done, it is not giving very good So this is something like, you follow on parameters. So this is nothing but a conventional functional echo parameter, and you have been following it. Since long you have been doing it. But then you get to see the problem in that. There is a problem. Okay, so that problem we need to solve somehow. Somehow we need to think out of box. Okay. So that is very important, and with whatever commodities, whatever facilities you have, you need to think out of box. So if you think out of box, only then you will be able to achieve the final goal. So you need additional parameters to know your RV functions. Okay, that is one thing. So the best way is to TAPSI. TAPSI is nothing but a tricuspid annular plane systolic expression. This is a full form. It is nothing. What happens is heart contracts like this also. So what we are doing is, where the tricuspid valve is attached to the RV valve, we are calculating the movement and how much it has moved. So that movement will tell me how much it has contracted. This is what I am doing. It can be done by M-mode, normal, or by tissue Doppler. Two way. But basically it is doing the same. And we can do in both distinct. Here. So we can do it in the lateral wall here and in the medially towards the septum. So that I can know the movement of both sides. Why it is being done in both the ways? Because basically this parameter and everything is being done in adults. In adults you get MI, myocardial infarction. So that affects the selected part of the body. That does not happen in newborn, but this is what we have extrapolated from the adults. Okay, so they do TAPSI in the towards the septal side and towards the wall, lateral wall. Okay, so when you do this, basically your M-mode passes through this and it records the movement, but how much that is in systole it will come down, in diastole it will move up. So how much it has moved. Okay, this is in normal 2D with your M-mode, and this is actually it is in tissue Doppler. Basically, tissue Doppler is nothing. What tissue Doppler does, the normal blood Dopplers you do, isn't it? So what we are doing, we are doing catching the velocity of RBCs. Okay, similarly, the tissues also break up in the wall, so they also move. So what you are doing is, machine is catching the movement of the tissues, Dopplers of the tissues. So that's why we know tissue Doppler. Why this tissue Doppler is in calculating that? It will give you the same result. Why it is better than this? Because here the movement, here the movement of blood is similar as blue and red, but here you don't know where to put the cutoff. Here you can clearly know the where to put the cutoff. Here where this blue and red bifurcates, that is the point I need to calculate. So the perfection is better in tissue Doppler color, tissue Doppler mode as compared to animal. That's the only difference, nothing much. There are further details, I don't want to go into that. But the crux of this is, this gives you a better cutoff line to put your marker if it is in the tissue, Doppler will be red and blue, instead of just 2D black and white. Okay, this is where you need to do it. So this is how you do it in black and white. Why I am not showing tissue Doppler in this? Because most of the machines what you will be using will not have tissue Doppler. But it doesn't mean that you cannot do your taxi. You can very well do taxi like this. Just by inverted 4-chamber view, you bring this lateral part of your wall of RV into picture, put hit M mode and cross this, where this mode is there, where this microphone mode join the lateral one, you put the line through across that and then hit M mode. It will give you something like this. And then you can calculate how much, what is the difference between this point to this point, and that is not, that is the your taxi. So this ratio, I will skip the ratio. Okay, so taxi normal in term basis it is. Some people say it should be more than 8, but it range is 6 to 9. In preterm it is 6 to 7. But in preterm it is less than 4. It is bad. In term basis it is less than 6. It is distant. Taxi. Okay. This again is, what is this? A Piper 4-chamber view, and what parameter we are trying to do in this? Ejection fraction. By sensor, isn't it? So similarly, you can talk like why can't we do the ejection fraction of right ventricle? But we have discussed the shape is not proper. Okay, in a Piper 4-chamber, but we can catch that posterior wing of your RV by doing 3-chamber view. In 3-chamber, you will get the almost 70 to 80% of RV volume. Okay, this is what this is your anterior chamber or anterior part of the RV, and this part where it goes back is the posterior part. That's why your RV is doing EF in a Piper 4-chamber view is not reliable. Okay, so that's why we do this 3-chamber view. This is 3-chamber view. In this, we will see the posterior part of the RV and the interior and anterior part, the whole thing. So this, by tracing this, you can do the EF in this 3-chamber view. How to do the 3-chamber view? You can do it in two ways. So this is a 3-chamber view I'm doing in the same way we are discussing. So in this, one is where you do the short axis view. Okay, parasol short axis view. Similarly, you put the probe there and try to rotate it anti-clockwise. From 1 o'clock, you try to bring it towards the 12 o'clock. Okay, then you will get 3-chamber view. Okay, or a Piper from apex, you try to go towards the 2-chamber view. So again, it is from 3 o'clock. You need to rotate anti-clockwise and bring the probe towards 11 to 12 o'clock position, and you will get 3-chamber view. So this is again that one I was showing in the Piper 4-chamber modified, and this is parasol short axis modified. Instead, from 1 o'clock, okay, you have to bring a bit anti-clockwise, you have to rotate and sweep up, bit upward. Okay, you will get 3-chamber view. We'll show you on the station. It is similar, like this is as Windows is saying, you just have to rotate anti-clockwise and sweep up, you will get 3-chamber view. This is how you will place again in end diastole and end systole, big and small. In that, you will have 2 valves involved in this. So this is your, one is your tricuspid and one is your pulmonary artery valve. So those 2 have to be closed. If you are tracing the area, your tricuspid valve and pulmonary artery valve both should be closed. This is how it will look like. Again, in parasternal short axis, your this probe orientation marker is up, but in this pitch under view it is down here. Okay, this thing you need to keep in mind. Okay, so this we have discussed, everything we have discussed. I will skip all this. Isn't it? We have discussed everything. I will skip all this. This also we have discussed. So this slide just shows you that sometimes you observe that LV is dysfunction, RV is normal, but RV is dysfunction, LV is normal. But eventually, if one ventricle is affected, is going to affect the other ventricle. After 2 hours or 3 hours, your RV function decrease will lead to LV function decrease. So that is very important. That's why you need to act fast. One will lead to other. Tissue Doppler imaging, I have just discussed with you. This is basically this video is showing that heart is majorly formed of 3 types of fibers. One is longitudinal, one is cross section, and one is circumferential. Circumferential is like this, cross sectional is like this, longitudinal is like this. So this is what it is showing. Basically, it's showing the same. So different part of the heart is being formed by muscles at different angles. Why you need to know? Because again, when you do the Dopplers of the blood, you need to know the direction of the flow of the blood. Similarly, for tissue Dopplers, you need to know the direction of the muscle fiber. That's the only thing. That's how you relate it. Okay, and that's how the tissue, when you put into the apical port chamber, put the tissue Doppler, this is how your heart will look like. It will look red and blue. Again, see, when your RV is contracting, this is your heart, this is where your probe is. If your RV is contracting, your blood from RV is going out through pulmonary artery. So it is moving away from the probe. So it will look blue. So, suppose if I am doing tissue Doppler, if my muscles are contracting like this, probe is here. So while the contraction, the movement of the tissue fibers will be downwards, isn't it? So it will be towards the probe. So it will be red. So if the movement of the tissues will be opposite to the movement of your blood. If your blood looks blue in the Dopplers, in that your tissue Doppler, your tissue movement will look red. So that's why. See, this is, I don't know, in PDA, they must have shown you the mitral valve Dopplers. In that, you have EA ratio and IVRT to measure. So this is nothing, this is basically inflow of mitral valve and this is outflow. But here it is ulta. The inflow is down, this should have been up in the when we do the blood Dopplers. But in the tissue Doppler, we say EA dash, what we call this is E dash A dash. And IVRT is up. Why? Because the movement of the tissues are always opposite to the movement of the blood. Okay. And when we do the Dopplers in the mitral valve, in blood Dopplers, it is not possible to calculate IVCT. That is isovolumetric contraction time. We always say we ignore it because we don't have the measure in the machine to measure that. But in tissue Dopplers, we can measure. So it can again give you additional information. So that is a benefit of this. Okay, then how to significantly judge what is A dash, C dash, and IVRT? It is very much similar to what we do it in the blood, but the parameters and graphs are different. Okay, so this is something you need to do once you are very well versed with all the normal parameters of it. But this is just to give you an idea. This is how it will come in the machine. So why it is important? Because it gives you like which part of the right ventricle is dysfunction, medial part or lateral part. So that gives you a lot of information. Okay. This is how for longitudinal you do it when the heart is being cut. Longitudinal. And this is then you do it in 2 parts because nature is longitudinal muscle fibers and circumferential. So you do it in longitudinal and circumferential is like this in parasternal short axis. So this is parasternal short axis, capillary muscle beam. This is what tissue. These are the caustic windows. So this is longitudinal movement of the tissues. it divides the wall into different sections. Because in adult, you need to know which artery has been blocked. So the section that is affected, that artery is blocked. Okay, this is how it will look like. Just by seeing, see now, movement is, contraction is low. Just by seeing the amount of redness going up and down, you can judge. So just by seeing it, it is no more subjective, it is objective. See this. It will come in the cross section also. This is radial. See. Can you see the redness and movement is very normal. And this is abnormal. Can you see? Just by seeing the color, intensity, and movement, you can start away, you can judge, okay, this is not normal. Okay, and just it will show you the normal septum. It will show you, see. This part of the septum is affected, isn't it? The movement here is very abnormal, decreased, rest is normal. So just by seeing the color and the movement, you can judge that which part of the septum is affected. So that's what additional information you will get. Okay, so there is another what we say is blood spectral imaging. You can see this. This is normal flow of the blood, and this is in PDA. You can see LALB is directed in this. This is HSPDA. And this is LALB related. But did you see the amount of color blood which was flowing? आपने नोट किया दोबारा amount of blood देखिए right side वाले में and left side red and blue the amount of blood you are you able to appreciate? But in normal color Doppler you are not able to appreciate the amount of blood which was flowing through the vital blood. By doing the speckle, you can even just see the amount of blood which is flowing through across it, just without doing any readings. What the speckle taking is doing, here the whole flow of the blood RBCs is look as red. It marks the RBCs. The speckle factor. Speckle is nothing but small speckles. It picks up all the RBCs. So it will give you the amount of RBCs in that area. So that's why it looks like this. So this baby then ended up on nitric oxide. So this baby ended on high frequency. You can see this baby is on high frequency on nitric oxide with map of 26. Okay, and now it started maintaining saturation. So was 3 ppm with shock. So started maintaining saturation on this parameter. Now SpO2 which was in 90 has gone up to 97. Okay. So TAPC which was been done was 6. So term baby 6 less than 6 is bad. So TAPC showed that there was RO dysfunction. That's why the TR was not reliable. Fine. So then what has clearly showed there is RO dysfunction, and then it's a severe PPHN. So if it is RO dysfunction, severe PPHN, we need to start some pulmonary vasodilators, and that's why we started with the nitric oxide. So what else? Now there is a severe pulmonary hypertension and RV is dysfunction. What else we need to look in this to treat this? What else we need to look into this? Okay, RV dysfunction is there. There is metabolic, there is low cardiac output state. So RV dysfunction will be there. But I'm just now concentrating on RV. What else I should do to release this RV? One I have done, I have put this baby on high frequency. I started nitric oxide. What else I can do to relieve RV dysfunction? Okay. So need some vent out, isn't it? Because मेरा RV का after load is pulmonary hypertension. I'm trying to relieve that. So what I need to do is I need to look for PDA whether it is open or not. Sometimes if there is severe PPHN and RV dysfunction is there and babies are not improving as you want, you start prostaglandins. So what happens with the prostaglandins? One, it is a pulmonary vasodilator and it acts through the different route as what from where the nitric oxide is working. Two, it gives you a vent of valve for the RV. So PDA, the blood is shunted out. So hence your RV dysfunction improves and your baby improves. So I have to look for PDA whether it is open or not. If closed, then we have to start with the prostaglandins. Babies we do it. So PDA when we did was open. was 4 millimeter. So we need not start with the first one. And it was shunting 70%. It was bidirectional shunting, but majority it was shunting right to left. So that also showed that there is a severe pulmonary approach, isn't it? So we started with the vasopressin. Okay, as mean blood pressure went down from 38 to 31, we hold sildenafil, which the baby was on. Milrinone was started. Spectral tracking was being done. Okay. And what this thing tells, I don't go into this. Strain rate decrease, velocity maintain. There are two things we do on spectral tracking. One is strain rate, and then we strain velocity. This one differentiates whether your myocardium is weak or your afterload is high. Okay, if your strain rate does not change, okay, if your afterload value after load to LV was not an issue, means if your strain rate remains same, does not change, that means your afterload is high. Okay, if your strain rate changes, it decreases, it means afterload is not a problem, or your myocardium is a problem. And why the myocardium is a problem in this? Because this baby is hypoxic, OI was very high. Number 2 was acidotic. So your myocardial contractility was affected. So if in this baby, what I need inotropic agent, not a vasodilator agent. My afterload is not, I was not able to get that information from a normal echo. Now I know my afterload is not a problem. The problem is my myocardium. So I need something to augment my myocardium. I don't need something which to decrease my afterload. Clear? So dopamine is not a good. Dopamine will be bad because it is not very strong inotropic agent. It causes vasodilatation. I don't need vasodilatation. I need something which is very good inotropic agent, which increases the contractility of my heart without touching my afterload. Milrinone can be thing, but if your blood pressures are low, it is not a good idea to start with this thing. My epinephrine will be a good this thing. Will be a good drug to start in this thing. And now it has been documented that low dose epinephrine is a pulmonary vasodilator. We use very often epinephrine in shock babies with PPH. Norepinephrine is again dilator in low dose, but it's not inotropic agent, it's a vasopressor. So I don't need to have any vasodilator. I need inotropic. I need to maintain calcium. I need to have a good thing which contracts my heart. That was the only thing which I do. You calculate your blood pressures and then you see, but other thing is BCF, circumferential shortening. That is one thing you can do. Yeah, I haven't told because there will be too many things for you because I am skipping although these are things which are very advanced things. Once you are not used to these things, it will be bad for you. You won't even remember this. In some, it's like in this case, this was useful to us, isn't it? TAPSE was useful because we were able to decide on whether we need to start endomethacin or not. Oh, sorry, not endomethacin, prostaglandin or not. And then this was useful because this baby oxygenation improved, but there was an issue with my perfusion and cardiac output. So I was not able to make whether your contractility is because of myocardium or my afterload is high. And I've already started vasopressin in this thing, isn't it? So if that is high, I need to know if my afterload is high, then I need to stop my vasopressin. But this spectral tracking clearly showed me that afterload is not high. It is not because of afterload. It is because of myocardium. So that gave me the indication. Now I need to start with epinephrine. Got my point? Yes. Good, but in high doses. Like high doses, I would say we start with 0.05, but when it crosses 0.2, then its alpha action is very pronounced. Till that, its alpha action is not very pronounced. But from 0.1 to 0.2, its inotropic agent action will be good. So its effect on beta receptors will be good. We always start because we are already on vasopressin, so we always start with 0.05, and then we titrate up. But we tend not to go more than 0.5. Because then the vasopressor action, and then in that time, that dose, it will probably vasoconstrictor also. So whatever you have achieved in oxygenation, that will also be reduced. Exactly, we don't have studies for that. We don't know how to follow that. But there are studies in pediatric and this thing adults. But newborns, we don't have much of the studies to have clear cut that at what dose, how much will be the effect on that. But that will be something good to do. Okay, so this is what we did. We started with epinephrine and we stopped milrinone. Why we stopped milrinone? Because the blood pressure was coming down and it decreases your diastolic blood pressure, milrinone. And then eventually, as I told, we had to start with the NORAD. Okay, but for that, why we started with the NORAD? Because vasopressin already started, but the main issue with the vasopressin is it decreases your urine output and it becomes very much bloated. Okay, so we have to stop vasopressin and switch over to NORAD for that action. Okay. So this is how. This is just a case to show you that your conventional echoes gave you some information, but there was some additional information you needed to know. This is how we get it from TAPSI and from spectral tracking or tissue Dopplers. So then again the thing comes, but the TAPSI is being now very commonly used because it is reproducible. The variation is less, it is reproducible. So that's why it is a good parameter to use, very easy to learn. But
Expected. We will take the short lunch break. Shall we meet up again in half an hour time? Is that okay? Now it's already 2:12. So we'll.
नहीं वो मालूम नहीं है सर, वो हमारा सेक्शन नहीं है। मैं बोलता हूँ किसी को
ಇಲ್ಲ ಅವ್ರು ಹೇಳಿದಾರೆ ಸಕ್ಕೆ ನಮ್ದೆಲ್ಲ ಆತರ ನೋಡಿದ್ರೆ ನಮ್ಗೆ ಇವಾಗ ಎಲ್ಲ ತುಂಬ ಮಾಡಿ ಪಾಸ್ ಆಗಿದ್ರೆ ನಮ್ಗೆ ಬೈತಾರೆ ಇದು ಸರಿ ಇದು ನೀಟ್ ಕೊಡಕ್ಕೆ ಇಲ್ಲ ಅಪ್ಪಾಜಿ ಯಾರು ಇರ್ತಾರಪ್ಪ ಯಾರಲ್ಲ
ಇರೋದು ನಾವಿಬ್ರೆ ಗುರುನ ಬಿಟ್ಟು ಬೇರೆ ಯಾರು ಇಲ್ಲ
ಅವ್ರಿಗೆ ಬೇರೆ ಏನು ಕೊಡಕ್ ಹೋಗ್ಬೇಡಿ ದಯವಿಟ್ಟು ಅದನ್ನ ನೆನ್ಪು ಮಾಡಿ ಸರ್ ಎಷ್ಟ ಸರ್ 5 ಪ್ರೆಸೆಂಟೇಷನ್ ಇದೆ 5 ಜನಕ್ಕೂ ಇದೆ We wait for 5 minutes for the delegates to come, then we'll get it started.
ಅಲ್ಲ ಚೆನ್ನಾಗಿ ಊಟೋಡ್ಬೇಕು
I think for the post-lunch session,
I know it's difficult, so we will have a conversation, but now we have something which is little more advanced. How many of you are something new? So Dr. Prakash Vizgar is the head of department of neonatology at CMO Neonatology Bangalore, and he was a specialist in the oscillators and lung recruitment. So we would like to have this picture. Thank you.
Yes, sir. Yes, sorry. So your PPT, you have sent it to. What's the name, sir?
Prakash. It is not there. I think it will be in one folder.
Hello. What is it?
ಎಲ್ಲ ಹುಟ್ಟು ಹೋಗಿದ್ದಾರೆ.
ಅಲ್ಲ ಈ ಟೈಮ್ ಅಲ್ಲಿ
Hello.
ಒಂದು ಕಾಲ್ ಮಾಡ್ತೀನಿ. ಹಾ. ಹಲೋ. ಹಾ ಅಲ್ಲ ಎಲ್ಲಿದ್ದೀರಾ? ಅದೇ ಇದು NIE ಅಡ್ವಾನ್ಸ್ಮೆಂಟ್ ಸ್ವಲ್ಪ ಬನ್ನಿ, ಅದು ಸ್ಟಾರ್ಟ್ ಆಗ್ತದೆ.
ನಂಬರ್ ಊಟ ಮಾಡ್ತಿದ್ದಾನೆ ಫ್ಯಾನ್ ಅಲ್ಲ ಅವು AC ವರ್ಕ್ ಆಗಲ್ಲ, ಹಾಕಿದ್ರೆ ಸೌಂಡ್ ಬಂದ್ಬಿಡ್ತಾವು. ವರ್ಚುವಲ್ ಮೀಟಿಂಗ್ ಅಲ್ಲ ಸರ್ ಇದು. ಎಲ್ಲ ಸೌಂಡ್ ಬರ್ತಾವು. ರೆಕಾರ್ಡಿಂಗ್ ಡೈರೆಕ್ಟ್ ಕೊಟ್ಟನಲ್ಲ ಮೇಡಮ್, ಕರೆಕ್ಟ್ ಮಾಡಿದ್ರಲ್ಲ?
ಅಲ್ಲ ಅದು ಆಗಿದೆ. ಇವ್ದು
ಪ್ರೆಸೆಂಟೇಷನ್ ಇದೆ ಸರ್. ಎಲ್ಲಿದೆ ಸರ್ ನಿಮ್ದು? ಪೆನ್ ಡ್ರೈವ್ ಕೊಟ್ಟಿದ್ದೀರಾ?
ಪೆನ್ ಡ್ರೈವ್ ಕೊಟ್ಟು ಹಾಕಿದ್ದಾರೆ, ಎಲ್ಲ ಒಂದು ಫೋಲ್ಡರ್ ಅಲ್ಲಿ ಹಾಕಿದ್ದಾರೆ. PPT
ಅಂತ ಹಾಕಿದ್ದೀರಾ? ಸರ್ ಇದನ್ನ ನಿಯೋಕನ
ಓಪನ್ ಮಾಡ್ಬೋದು.
ಎಲ್ಲಿ ಸರ್ ನಿಮ್ದು?
ಪ್ರಕಾಶ್.
ಆಮೇಲೆ ಅದು ಪಾಯಿಂಟರ್ ಚೇಂಜ್
ಮಾಡ್ಬೋದು ಸರ್, ತೊಂದ್ರೆ.
ಇಲ್ಲಿಗೆ ತೋರಿಸ್ಬೇಕಾಯ್ತು.
ಇಲ್ಲ ಅಲ್ಲಿ ಇಲ್ಲಿ ಇದಕ್ಕೆ ಹಾಕಿದ್ರೆ, ಈ ಲ್ಯಾಪ್ಟಾಪ್ ಹಾಕಿದ್ರೆ
ನೋಡಿ ಯಾವ್ದು ನೋಡಿ
ಇಲ್ಲಿ
ಅಲ್ಲ ಇದಕ್ಕೆ ಹಾಕಿ.
ಯಾವ್ದಕ್ಕೆ ಹಾಕ್ತೀವಿ? ಇದಕ್ಕೂ ಅದಕ್ಕೂ
ಇದಕ್ಕೆ ಹಾಕಿಲ್ಲ. ಟ್ರೈ ಮಾಡಿ.
ಇನ್ನು PPT ಬಂದಿದೆ. ನೆಕ್ಸ್ಟ್ ವಾಟ್ಸ್ಆಪ್
ಮೂವ್ ಫಾರ್ವರ್ಡ್ ಸರ್. ಅದು ಬ್ಯಾಕ್, ಅದು ಫಾರ್ವರ್ಡ್ ಬ್ಯಾಕ್ ಫಾರ್ವರ್ಡ್.
Good afternoon. Can you start?
ಆಯ್ತು ಆಗ್ತದೆ.
So it's been a day where there's a lot of confusion, a lot of technical issues, and there are a lot of people who couldn't, our colleagues, delegates couldn't join us virtually. So when you have a situation like this is what typically happens in NICU. When you land up in a problem where you can't ventilate a baby on conventional ventilation, then you need to see which mode can you ventilate a baby. So one of the modalities of ventilation in neonatal care is high frequency ventilation.
Host screen.
ಪ್ರೆಸೆಂಟೇಷನ್ ನಡೀತಾ ಇದೆ ಸರ್. ಅದು ಪ್ರೆಸೆಂಟೇಷನ್. Which one switch off?
Sorry about that.
Hey, kudi sundar, kudi.
So my topic today is to discuss about high frequency ventilation. So in a recruitable line as well as in non-recruitable line. I think as Anand was asking you all, now when you spend the whole day how the conventional ventilation works, but in high frequency, we are still ventilating the baby, but the principles are slightly different here. So we are trying to achieve what we couldn't achieve on conventional ventilation. These are the two diagrams which are commonly used in most of the centers in India and in overseas. So today's objective of discussion is the basic principles of high frequency. When do we start high frequency? What are the different types of high frequency ventilators? And how do we set up high frequency? Weaning a child from the high frequency and what are the complications? Now this is the token hammer is a high frequency. You can see a machine over there. Animal model. Where he starts to push air inside the lungs and he try to see what are
What is his name?
at the tracheal level as well as at the alveolar level. And we know that the variation happens by diffusion. So what we found out was that when you ventilate any person or any child by this way, probably you try to prevent ventilator induced lung injury. So then there were a lot of studies happening at the same time. So when they saw that, of course, there is a different ventilator lung induced injury. And what we do is in this machine, the ventilation rates are much high. So the rates are not kept at 30 or 40 on a conventional ventilation, what we see. So the rates are quite high, it's 150, 200, 250. So I'll go in detail about that. And the tidal volume, what we deliver to the babies are even less. So it's hardly around 1 to 3 ml per kg. So how do you define high frequency ventilation? Is by ventilating a baby at very higher rates, that is supraphysiological frequency. Frequency is nothing but the hertz, that's the vibrations. And we use very less tidal volume, which is less than the anatomical distance. Now, how can we achieve that? Is we need to have in a device a piston which pushes the air, and then there is a diaphragm. So when the air is pushed in, the diaphragm vibrates. It's like a speaker diaphragm, and that pushes the gas in. And I mentioned here about the frequency, which is kept somewhere between 180 to 2400. That is the respiratory rate. That is measured in hertz. Remember, 1 hertz is equal to 60 breaths per minute. And the air vibrates in and out of the lungs. So air goes in, air comes out. And mind you, in high frequency, both inspiration and expiration are both active. Now, this is one of my favorite slides. I always put this, and I think you probably should start using this slide. Why is, if you are going to be an intensivist and you are going to ventilate most of the babies in ICU, and an intensivist should know what is he doing when he is ventilating a child. So I think it's a kind of pointer in this. Probably you can just visualize. There are two diagrams. This is a picture representation of the alveoli as well as the pulmonary capillaries. That's an electron microscope picture of a pulmonary capillaries. What you can see is this is a pulmonary capillary, and what you are seeing here is the red blood cells. Now, why I have put this is, if you know the physiological part of it, then you know that what you are trying to do is ventilate. So we all know that when we ventilate a child, we want to oxygenate and eliminate the carbon dioxide. And this is where the oxygenation happens. This is the
blood-gas barrier. So you can see the thin rim of there. So this is alveoli in electron microscope, and this is where the diffusion has started. So in that area, imagine you try to ventilate them and land up in a problem like this. So this is the next diagram which shows that what happens when you ventilate a child. So again, you can see a normal alveoli, and when you start ventilating the baby, it will go into a cascade of events due to various reasons. One, putting the baby itself on invasive ventilation will induce a reaction where there's constant infiltration of so many chemotactic factors, interleukins, proteinaceous fluid. And what you can see here is there is a hydrogen membrane formation, and you can see the distance between the pulmonary capillaries as well as the alveolar surface there. So there's increased distance, fluid formation, and you have difficulty in ventilating these babies, and they start having constant hypoxemia. So this is very important to remember, because you need to prevent this. And how can you prevent is one of the biggest challenges. Now, we all have heard we are moving away from invasive ventilation to CPAP if we can manage the baby on non-invasive modes of ventilation. So which is quite commonly used in most of the nurseries, and that is how we look forward. But there are some set of babies which requires this kind of support so that we can pull out from their major illness. Now, how does it happen? Because we ventilate them with high pressures, which is called barotrauma, the volume trauma, and there is a non-synchronized way of ventilating. Sometimes in these babies that causes increased inflation and deflation of the lung, which is called as atelectatic trauma. And we know that as the infection setting or because of the word distension and when the distension, there is biotrauma. There's inflammatory mediators which starts coming into the lungs. And we all know that oxygen is not safe. It can induce oxygen-induced free radical injury. So histological picture of a spontaneously breathing child, how the alveoli looks, nicely defined alveoli, whereas in a mechanically ventilated child, you see a lot of collagen and other debris sitting inside the alveoli. Now, high frequency ventilation. This is the graphic representation of what the graphs look like. Okay, in high frequency. You probably heard Navin's talk. What are the pressure volume curve loops? These are the loops. What is basically set in high frequency is basically 3 to 4 parameters. So what we set is amplitude, the frequency, and this is the mean area pressure. When I incorporate this on a conventional ventilation, so this is a graph you can see. This is the conventional ventilation graph, and this is the high frequency. So the vibrations which the machine creates is what we are seeing over there. And if you see there, on conventional ventilation, there is a slope that is inspiratory as well as expiration. So on either ends, you are either probably going to over ventilate or under ventilate, which is not good for neonatal lung. So whereas in high frequency, there's a constant vibration, and you are keeping a mean airway pressure. The central line at around 30 is the mean airway pressure, and the baby's chest wobbles, it vibrates. That is how we are going to ventilate in high frequency. What do we do in high frequency? This is a comparison from conventional ventilation. So the rates, you can see a huge difference. The tidal volume, which are less, alveolar pressures are even less. Then expiratory volume is normalized, whereas in conventional it is either low or probably not great. The gas flow, of course, to push the gas here is quite high, and both inspiration and expiration is high. Now, how does the gas flow? You don't need to remember all the details of it. We know that when the gas flows in a kind of a tube, it flows in various directions. I think this is more of physics. But we know that the majority of the gas which goes into the alveoli is by diffusion. So if you see the lower part of it is what is this perfect. So those are the alveoli. The principles are saying the diffusion of gas happens at the alveoli capillary interface. There is collateral ventilation between the alveoli There's something called as laminar flow as well as pendulum method. So if one annula is over distended, the air goes back and starts to open up the annula which is atelectatic. This is collateral. These are the three main ways how in high frequency gas flow happens. Now there are various machines with over here. So what I commonly use are sensor readings, and I have used SLA2000. So the true oscillator is one which has very high frequency, which is 3100A, that's used for units. I haven't used the rest of them. This is the list of ventilators which you probably can see in the market. Now, sensor medics is one. This is a true oscillator, which I have used extensively, and all of us we have used. And basically, what you are seeing here is the pump, and there is a schematic representation of how the sensor medic works. So you can see the pump there, and the black thing is a diaphragm, and as the air pushes in, the diaphragm vibrates. That is how baby gets ventilated. And this is a circuit on a high frequency. So you see an inspiratory, the bias gas flow occurs, and the diaphragm starts to pushing from that way. So the air goes in, goes to the patient, and whatever is going back, both inspiration and expiration is active, so it comes out. So that is how you constantly feel that you get a sustained pressure in the lungs. So what are the indications for high frequency? So as we discussed earlier, initially we all start on conventional ventilation. And if you are failure on conventional ventilation, then you need to think about what are the different types of ventilation. So one is that indication, because an aspiration syndrome, pulmonary hypertension, either because of hypertension or as accelerated pulmonary hypertension. Whenever you find a child who has pulmonary hypertension, so basically the heart compliance is less, and that's the time where you probably have to oscillate RDS in a borderline frequent basis. RDS oscillator is a very good device in order to pneumonia, you are not able to ventilate atelectatic cases. When do we think of
This is going. No, this will go. The screen, the speaker, this video will, they can view this video. That means they need to host it.
So high frequency oscillator, whenever
We cannot do anything. Because the whole links which they have given is to join a meeting. So we cannot do anything. We can join a meeting and we can listen whatever they say.
So, but by chance, if you have reached more than 20, 28, with a tidal volume of more than 6, and the mean airway pressure is 12 to 14, then you should seriously think that okay, this baby probably requires a different way of ventilation, or there is some other issues probably we need to address. So you need to start,
Now screen share
think of calling up, where you can think of referring this topics. So now we have clinical options as we discussed in the previous slide. Now, a lot of centers we use the last resort as a rescue. So when you are paid on conventional ventilation, when you have tried all the strategies to ventilate this baby, or if your baby is deteriorating, then you seriously have to start again. Probably this child we are not going to get ventilation, so we need to refer. That is the most largest scenario in most of the centers in which
Central people English and check. Finish 5 minutes.
you would achieve what you are supposed to achieve. Then they would have
ಅವಾಗಲೇ ಲಂಚ್ ಬ್ರೇಕ್ ಅಲ್ಲಿ ವರ್ಚುವಲ್ ಅಲ್ಲಿ ಯಾರು ಬಂದಿಲ್ಲ ಕುಸ್ಕೊಂಡು ಇದರಲ್ಲಿ ಲಾಗಿನ್ ಆಗಿತ್ತು ಸೊ ಅದಕ್ಕೆ ಇದನ್ನ ವರ್ಕಿಂಗ್ ಅಲ್ಲಿ ಅವಾಗ ಯಾರು ಬಂದಿಲ್ಲ.
Now what do we do on settings? So you have the registration of the
ಬಿಡಿ.
So when you measure the pressure in oscillator as well as the pressure, these are the two graphs. When you introduce the flow as well as the pressure, you can see on the conventional both the inspiration and expiration are almost the same at the terminal angle. So this is a trichlinium, bifurcation, and terminal angle. Whereas in oscillator, we can see only less tidal volume goes in, which is this is what I can properly reduce that now, as I told you earlier, so inherent oxygenation.
ಅದು ವಾಲ್ಯೂಮ್ ಇನ್ಕ್ರೀಸ್ ಮಾಡಿ ವಾಲ್ಯೂಮ್ ಇನ್ಕ್ರೀಸ್ ಮಾಡಿ
Of course, you have the clinical evidence that the baby is already reached to the maximum of all the pressure settings here. Sleep of 28, sleep of 8, MAP of 15, FI to more than 60, 70, 80%. And I think you all have read about oxygenation index. Yeah. Okay. So when oxygenation index has reached more than 50, we need to think about starting the beta high frequency. So how do we set the ventilator? So we set the ventilator. The first knob which you use, which you see on the workstation, is the mean air pressure. So the mean air pressure is set basically 2 to 3, centimeters of what we have for the conventional technique. Sometimes we need to start higher or you might come down based on how the patient responds. Amplitude, just have to remember y is the number of the mean area pressure. Or we need to do a sum of peak and peak is another option which you can compose. Frequency, in terms like this, is 10 hertz, which is basically 10 times 60, which is 600 hertz. In free term, it is 12 times 60, which is 20. And inspirated time in the machine is already set 33%, which gives a ratio of 1:2. So this is the bias flow, the flow of the gas which flows in. So you need to remember only two numbers. We use, because we are all electrologists, we use either a return very rarely or in return around 10 to 20 meters per minute is what we need to think of. And as I told you about the frequency and the hertz. So just a quick look at what is mean area pressure, because it's very important. So mean area pressure is the curve, the area under the curve. So it is basically the CIP and P along with other calculations which is there. So if you try to increase the mean area pressure, you can see this everything change over here. So that basically means that we can manipulate better, oxygenation gets better, carbon dioxide elimination gets better, your IFI increases, everything happens. Mean area pressure is very powerful in an oscillator, which when you start using it shows a change in the regulatory parameters of the improvement of the child oscillator, then you know that the machine is working against the baby. So what is the ultimate thing is to achieve a functional residual capacity so that the lungs are open, because in any situation, either in autonomic aspiration syndrome or in PPHS, the best way to regulate a lung is to regulate and keep the capacity number. Because if you try to overregulate, the capacity changes and only not to. And the most important thing is the pulmonary blood flow is dependent on the functional residual capacity. So if you stretch too much, there is less blood coming to the pulmonary patches, pulmonary capillaries, and that land up regulation perfusion mismatch. Another important thing in oscillator is in a conventional ventilation, everything is mixed ventilation, oxygenation, whereas in high frequency, we have decoupling of both oxygenation as well as ventilation. What it means is oxygenation is mainly determined by mean area pressure. So you just have to remember this, then you can clear oscillator. So if you increase the mean area pressure, you probably increasing the oxygenation, or if you have the better oxygenation. Whereas the carbon dioxide elimination, ventilation part of it is basically by playing around with the delta, which is the amplitude and the frequency. So as I told you, a constant pressure is used to make the lungs and open. And clinically on which side, one is you can see that just vibrating. And also if you do an X-ray, you will probably found the rift spaces. If it is around 8 to 10, then you are ventilated probably open up the lungs. But there are sometimes we don't just go on that. Maybe just 7 to 8 weeks. The thing which is so this is how the lungs look once it's on oscillator. In fact, this X-ray I put it so that you can see the diaphragms pushed down. Okay, so that means you probably have you might have complications. We come to the complications of overstretching the lung. What is important here is to count the rates, and if you think that the baby has responded well, probably it will come down on the linear reflection, so that you optimize the ventilation. So the amplitude, the delta P, is basically how to control the CO2 and vice versa. So if you increase the amplitude, then you are increasing the tidal volume from that curve. So you are going to eliminate the CO. And the same thing, if you decrease. Whereas frequency is what the vibrations are, and that is what determines the crystal to move it how fast. Increase the and the displacement of gas may be not good. That can be explained.
Yeah, just connected. Yep.
So this is a very important slide. The next two slides, because a lot of people who are new to artificial intelligence, they get confused with this. Now, if you see that it's clearly explained, this is what the frequency which is set at 4 hertz. What basically determines, you can see there are 4 loops out there. Okay, and this is 8. I'll come to that next. So when there is 4 hertz, we can imagine what is the volume under those loops. Okay, what basically, if the lower the frequency setting, the larger the volume it is displayed. So you can see the volume is larger. If you see the next slide, I increase the hertz to 8. So you can see the number of curves over there are 8, but higher the frequency setting, the smaller the volume is displayed. So generally, when you're trying to ventilate, we keep the amplitude and we play around the amplitude, not with the hertz. So we fix the hertz. Very rarely we use the hertz. In case if you are run out of the option of changing the amplitude, then only one sets the hertz. So first thing you need to remember is that, and what is important in the next slide, what I would say is, always think if you want to decrease the PCO2 on an oscillator, try to increase the amplitude. It's like a respiratory rate. Just remember that way. Don't touch the hertz. Of course, if you decrease the hertz, the CO2s will come down, but when you're not able to increase further the amplitude, then you can think of. The same thing happens when you have high CO2s, what to do. So this is just a kind of a slide which you probably can remember. So on a conventional ventilation, ventilation is mainly by frequency times tidal volume. Whereas in high frequency, it is frequency times twice the tidal volume. So whenever there is a small changes in the volume density, like the delta P frequency and the discrete decline have a more significant effect on the signal denomination. So can you play this video? So this is a high frequency ventilator for sensor medics. So briefly you see the lungs getting inflated, and initially this kind of tightening as the linear. So once it is fully opened up, it will keep the lungs opened up. That is what exactly this machine says. You can see the tube is already started to vibrate. open this slide. Okay. So let me clear this also. Now, another slide which shows that on a conventional ventilation, the alveoli opens, closes, opens, closes. Remember this one. So you can see the alveoli continuously getting distended.
হ্যালো, বলছি অঙ্ক বিসিজি বলে কিছু জানেন, সেটা পাওয়া যায়?
So on conventional ventilation, during the expiration, the alveoli collapse, whereas in high frequency, during the expiration of the alveoli remains open. Okay?
এর বিসিজিটা রাখেন, অঙ্কটা রাখেন না?
So in hypoxemia, we have an option of increasing the mean air pressure and the FiO2. Whereas if the child is oxygenating the hyperoxic, we know that oxygen is not great. We need to reduce the FiO2 as well as the mean air pressure. If it is hypercapnia, the amplitude, and not touch the frequency, whereas hypercapnia will decrease the amplitude. I'll use this frequency as the last resort if I am not able to do anything much in amplitude.
আর বায়োভ্যাকে একটা।
So as I discussed you earlier, when there is overinflation, we need to reduce the mean air pressure and see how the baby responds. What is important in increasing the mean air pressure and its associated complication is, as we increase the mean air pressure, there is decreased venous rhythm and you might land up in hypotension. So you need to keep in your mind that as soon as you put the baby on high frequency, there is always a possibility that this might lead to hypotension. So you might have to think of giving some volume, and if you are regulating better, probably you can come down on the mean air pressure. Hypotension gets corrected. Sometimes we have to use active agents, so like dopamine, vitamin, and sometimes it is so bad that some babies are so unstable, you may have to think of probably discontinuing from high frequency, because you don't want a child to die from hypertension or cardiac issue related. But at the same time, it might die because of hypoxemia. So you need to see which is the best and right rate according to that. So what all you need to monitor: general monitoring, general assessment, ABG, chest X-ray, hemodynamics, end-organ perfusion. You need to do a baseline cranial ultrasound. You need to check for the ECG readings, chest figures, because that determines how the baby is ventilating and general medicine care. And the problems and complications are secretions. You can't disconnect the high frequency ventilator, do suction and connect that, because we recruit the lung if you open up the regulatory circuit. So keep in mind on hemodynamics. Though they were initially worried about the intracranial hemorrhages, but there is not substantial evidence saying that if a child is on high frequency, there is more incidence of intraventricular hemorrhage. You might overinflate, come down on the high frequency, especially the MAP. And keep aware about the CO2 levels, because CO2 can drastically drop and you don't want to cause hypocardia and cause cerebral injury. Meaning, basically, we deal from two strategies, either from high frequency to CPAP or switch over to conventional ventilation. And generally, we from high frequency, if you attain the mean airway pressure somewhere between 7 to 9, pressure is around 30-40%, amplitude is less than 25, and you know that the child has improved a lot in terms of gases as well as mechanical changes, which has given you the better gases. So the failure in high frequency is basically in babies who have lot of secretions, where you need to suck, and you're probably going to decrease the lung, then you have a challenge. And sometimes the bigger babies will start spontaneously fighting and oscillating because it's vibrating at the physiological level. You may have to use sedation and muscle relaxant. You are shied away from using muscle relaxants. But if you have a challenge and you're not able to, that is one challenge where you may have to do. Now the next few slides, I'll go quickly about non-recruitable lungs.
So there are only few conditions which you need to think about what is non-replicable lungs. Basically, these are the lungs which you can't recruit on a conventional ventilation when you're thinking of high frequency as a modality. One is PPHN, we have already discussed about how to manage pulmonary hypoplasia due to prolonged rupture of membrane, congenital diaphragmatic hernia. I'm sure you will all come across with the cases of diaphragmatic hernias. Pulmonary interstitial emphysema, you don't see much often nowadays, but 20 years back, we had a lot of these babies having issues, especially extreme preterm babies, cystic lung disease. PPHN confirmed by echo, and you do all the same things what you do on a conventional, giving surfactant, antibiotics, nitric oxide can be given on conventional, but better with a high frequency. You use the vasopressors if the hypertension and other adjuvant therapy like sildenafil, milrinone, and all those things. What is important in PPHN is to avoid hyper and hypoventilation. Try to have normal carbia, keep the saturations more than 92. Don't try to be lower and try to get 100% oxygenation. And as I told you before, we need to ventilate these babies on at a FRC, functional residual capacity, which is the most important technique to have pulmonary flow. And we know that when there is PPHN and pulmonary lung disease, high frequency is the only way of ventilating this baby. If there is PPHN with a pulmonary hypoplasia, because we don't want to damage whatever the alveoli which is kind of good enough by overstretching, so you need to think of high frequency. I just want to tell you one thing about this slide is basically if you see when you use a high frequency and nitric oxide, these are the number of responders on this side, that's the percentage, and these are the conditions. That's one is congenital diaphragmatic hernia, another one is a deconem aspiration syndrome, RDS. What is disappointing is when you use high frequency as nitric oxide, only 10% of them respond both with high frequency and nitric oxide. Around 70 to 80% of the diaphragmatic hernias don't do that. So the outcomes are not great if you are thinking. Whereas in comparison to other conditions, they are almost 40 to 50% responders when you are using high frequency with nitric oxide. And these are the few slides basically which shows pulmonary hypoplasia, the first and the second, and the third is the diaphragmatic hernia. Pulmonary hypoplasia due to secondary to prolonged rupture of membrane is that. And again, premature babies, only few centers do use high frequency as, but if you land up in a trouble where you don't have other options, you can think of trying, especially if there is respiratory acidosis and if your FiO2 is very high. Use of nitric oxide in preterm along with oscillator is not much. There are few studies, but it's not being recommended anymore. And this is the general management of congenital diaphragmatic hernia. I think you all know that the most important thing is not to back ventilate. And what is important is this part of it in this slide. What is important in ventilation of the congenital diaphragmatic, if you are in the safe zone, basically if you find a child who is at and you are ventilating, responding well, you are using less pressure, oxygen is less, you know that okay, this baby probably will do better, probably has better lung development, so, but when you hit Azara's zone, even if you send to the best of the best centers, even if you have high frequency as well as nitric oxide, as it should be the first line of the now there are few slides, so I just wanted to show you what is cystic lung disease. This is how it looks like. And there are other few slides. Again, cystic lung disease, where unilateral is extreme preterm babies. What is important in this slide is as the number of hours increases, like as the baby improves, and basically you can achieve this low frequencies, low linear pressures, so that you are not overstretching and allowing the lungs to settle down over time. And you can see the next slide, the last bit of it, at 104 hours at a frequency of 1 and a linear pressure of 7, and FiO2 is 21%.
this video was so effective in interstitial on a high frequency. The next slide is a bilateral cystic blood disease, again at different intervals, at different age. A child who is at 100% epilepsy, it has come down to 50% with a height of 5 and amplitude of around 10. So this will be, got better over time as it is. Sometimes this drugs keep healing and get better. But it is not that this is a magic, but some babies definitely works. Probably right. So the take-home message is, of course, high frequency is one device where you can use it. You have, and you know that it integrates babies at the physiological rates and at the low tidal volumes. We know that it uncouples oxygenation and CO2 elimination. Mean area pressure is the one important determinant to feed the oxygenation, and delta P controls the regulation of the CO2 elimination. Oxygenation is mainly by mean area pressure with CO2. CO2 elimination is amplitude and height. Hypertension, you need to be aware of it because, as we discussed earlier, these babies can have hypertension. Echo is a must, and you need to include whenever your baby is either going before or after the roll out of heart disease. And this is just a formula to calculate the mean area pressure. You know that the threshold of the mean area pressure is going more than 15, maybe 20, landing into the. Okay. So, nitric oxide is one thing in the workstation. So I'm not going to go in detail about the nitric oxide. So there's a rule of 20-20-20, which is more of a protocol rather than much evidence, but that works out most of the cases. So with that, I would like to end my talk. I'm sure if there are any questions, we can discuss. Babu Madhukar, the next talk. So the next talk is about high frequency and the use of high frequency on with tidal moment. Yeah, discuss about tidal moment. So he gives out what happens.
Next.
Yeah, what is the name? This.
It's not a good topic for a after lunch session. It's not a good topic. But then that's what I try to simplify and try to make it more easy to understand. this ventilation, most of the part is the water side of the program. It will work easily. Now, when we come to volume coming to volume kinetic mode of this volume kinetic mode may be part of there are so many benefits that are reduction, any kind of IPS, reduction, EPD, name mortality, any kind of everything is reduced. Volume kinetic. If you see Cochrane also shows there is beyond doubt in terms of hypocardia, so and so forth. All of them are.
Can I have it?
Volume therapy as a mode is a lot of benefit in terms of the fact that it can decrease the various kind of morbidities. Is it possible for volume therapy? Now, when you say we are something called as tidal volume. Tidal volume also target. In high-frequency ventilation, we are not doing tidal volume ventilation. We actually do dead space ventilation. When we are doing dead space ventilation, then is it possible for us to volume guarantee?
What is his name? Babu, right? 1 second.
So, continuing from the discussion. One is map. Map is this grid line. This line. This is the pressure above, or map is something that we calculate for ventilation. And two are added to the map, and we discuss the map. And movement of the ventilation across the pressure, the minimum pressure that we is called delta P, or this is called as amplitude. Number of times it does is actually frequency, and as we know, and these are the ones which actually are the characteristics. In addition to this, what we call it IE, we also know conventional. So as I was saying, compare the pressures in high-frequency ventilation and conventional ventilation. You see on the side of the device, which is the side of the ventilator, side of the endotracheal tube and at alveolus. The pressures are always same at ventilator, ET tube side or the side of the baby. But there is damping that occurs that is seen from from initial part of the ventilator, some amount of pressure over a period of time. There is no pressure that is ventilatory at the level of the alveolus. Why? We are actually dealing with the dead space. We are only doing dead space ventilation. So if you have to increase oxygenation, what we have to increase that, increase the pressure. And how does that mean? As I optimize the plant volume, helps you get the alveoli and also more distance. And if you have to remove the CO2, what is it? We have to increase the amplitude and the frequency of the two parameters. So how do we improve the CO2 by either increasing amplitude, this further helps in fixing the right volume and reaching the right volume for the distance between the CO2. And other parameters are the removal of fluid. When we come to oscillator, same thing also taking it to the part. There is something called when we are doing annual ventilation, ventilation, DCO2 is equal to volume square. Square actually time volume time volume square equals to so when we are actually increasing what actually happens is over time keep on the side volume square keep on also it's fine. So this is why the volume out. That is why the derivation what is the ventilation has it means there is zero ventilation. There is zero ventilation, there is high pH. Similarly, there is high CO2 also occurs. It is why when we do the pH CO2 like that comes out. Why that? So, in temperature regulation, what we do? Tidal volume into the rate increase. When we have to wash out CO2, we increase the rate and then CO2. But in high frequency ventilation, if we have to decrease CO2, we have to decrease the behind that is, we take a single waveform. This is a waveform. How do we increase this whole area? Either by increasing the delta P, which is by how we increase the area, or by decreasing the frequency. When we are decreasing the frequency, what is actually happening is area is increasing. This whole area is increasing. How we are causing more tidal volume to be released from the vapors. The more ventilation is actually more from the vapors. So decreasing frequency and increasing delta P, delta P, CO2. When we compare the ability of removal of very high and very unpredictable noise. So we have seen there are so many studies that show that in high frequency ventilation, the ability of the removal of CO2 is not manageable. We cannot like that. That is why we end up having maybe 7 hypothetical, which is over the we have caffeine result in increase in cerebral blood flow, which is how it is causing IVF. Coming to what is volume in tidal volume in efficiency. This is this volume. This is the tidal volume in efficiency. So in normal ventilation, when we are setting the tidal volume, there is increment in pressure. It's parallel action. Ventilation, the ventilator perceives 3 waves and calculates and puts fixed activity. In comparison to fixed tidal volume, delivers fluctuating activity. So till now, what we understand, what we are learning from Dr. discussion was, there is you have to fixate delta P. There is no fixation of delta P. Fixating tidal volume along in accordance to the tidal volume that we have fixed. There is fluctuation of delta P that is happening. There is fluctuation of amplitude that is happening. This is routine ventilation where this straight line is delta P. This is fixed. Routine conventional ventilation. But there is fluctuation of amplitude which is not normal, which is not occur. In volume guaranteed ventilation, the tidal volume is fixed, which is actually means DC was fixated, but for variance. So it is ability of the test of G to fluctuate in accordance with set tidal volume that we are working on. So as I was discussing, these are the frequency and this is the volume. When the volume guarantee is off on ventilator, it means we have a discussion on the water. When we keep on increasing the frequency, the tidal volume keeps on falling down. When the volume DC mode is off. But when the DC mode is on, tidal volume remains same always. So this is the reason why tidal volume keeps on falling down. Without you have to remove CO2, you have to decrease, you have to increase CO2, you have to increase. Here we don't have to do we don't have to just put the settings on and let the time volume, target time volume, you have to start. So many times in the past, they have shown or some way as common type of volume that we need to set up. But 1.5, what we are doing in our experience, all of the like we need effort, so the way one thing we need to remember, we have to see smallest price volume and in cost, good ventilation as well as ventilation. So just understand this is inflation and deflation. The PK lung is inflated. There is some amount of inertia that is operated, and the lung doesn't feel a point. After that, start inflating. After that, once you start inflating, still doesn't simulate inertia is inflation. Lung starts inflating. So this is the point where you have to do the area that is shown that is the point that is here. So there is a we have to the lungs to have ideal and breathe. What does evidence say about it? When the volume guarantee is off and the volume guarantee is on, tidal volume delivered as per the requirement. Off only delivered. Similarly, the DC levels are very common and there is much amplitude that is what we wanted. I think the ventilation also implemented reduction in reduction so what is the IASO that we need to set? Normal is without reading. It is okay to send that on this one, but we need to have 1:2 ratio because large amount of high like volume is going to transfer it to time, but we need to give sufficient time for it to come. Practical practice, it's not stated because there's no we have to follow the procedure of equipment. We have to set along beyond which we should not fluctuate. Like I told you, the baby is smaller, the 24 we can 25 we can make 1.5 as well as cycle. pH of the level. We have to reach a static issue. The issue to but the meeting mode again track like just like is a frequency, so the water is a frequency. So we need to achieve static maximum. So just as a practical guide, we will need to discuss it. Set an aptitude for max.
ನೈಟ್ ನಾನು ಮಲಗ್ಬೇಕಾದ್ರೆ 2 ಕರೆಕ್ಟಾಗಿ 6:30 ಬಂದ ಅವಾಗ ಬಂದವನು ಇನ್ನೂ ಗೊತ್ತಿಲ್ಲ ಅವ್ರು ಬಂದು ಅಲ್ಲಿ ಕೂರ್ಸ್ದವ್ರು ಅಷ್ಟೇ. ಇಲ್ಲಿ ಇವರು ಮಿಷಿನರಿಗೆ ಸಪ್ಲೈ ತಗೊಂಡಿದ್ದಾರೆ ಡೆಲ್ಲಿ ಅಲ್ಲ ಸ್ಕ್ರೀನ್ ಶೇರ್ ಮಾಡಿದೀವಿ, ಸ್ಕ್ರೀನ್ ಶೇರಿಂಗ್ ಅಲ್ಲಿ ಜೂಮ್ ಅಲ್ಲಿ ಆದ್ರೂ ಇದು ಲಿಂಕ್ ಅಲ್ಲಿ ಜೂಮ್ ಓಪನ್ ಮಾಡೋದು ಸ್ಕ್ರೀನ್ ಬರ್ತಾನೆ ಅಲ್ಲಿಗೆ ಬರ್ತಾ ಇಲ್ಲ, ಆ ಲಿಂಕೇ ರಾಂಗ್ ಲಿಂಕ್. ಯಾರ್ಯಾರು ಬರ್ತಾರೆ
ಏನ್ ಮಾಡಿರ್ತಾರಲ್ಲ, ಇದು ಒಂದೇ ಐಡಿನ ಡಿವೈಡ್ ಮಾಡಿದ್ದಾರೆ ಆ ತರ ಎಕ್ಸಾಂಪಲ್ ಹೇಳ್ತಿರೋದು 10 ಇರೋದು 13 ಇರೋದು ಸ್ಟಾಲಿ ಐಡಿಗಳು ಜನರೇಟ್ ಮಾಡಿದ್ರೆ ಅಡ್ಮಿನ್ ಒಬ್ಬನೇ 13 ಐಡಿ ಕ್ರಿಯೇಟ್ ಮಾಡಿದ್ದಾನೆ. ಹೇಳೋದೇ ಕೇಳಿ, ಅವರು ಜೂಮ್ ಅವ್ರು ಏನ್ ಮಾಡ್ತಾರೆ ಗೊತ್ತಾ, ಚಾರ್ಜ್ ಮಾಡ್ತಾರೆ ವರ್ಷ ಓಡಿಸ್ತಿರೋದು.
ಬೈ ಬೈ ಸಿ ಯು
ಪೇ ವರ್ಷನ ಓಡಿಸ್ತಿರೋದು. ಪೇ ಮಾಡಿದ್ರೆ ನಿಮ್ಗೆ ಆರಾಮಾಗಿ ಶೇರ್ ಆಗ್ತದೆ, ಪೇ ಮಾಡಿಲ್ಲ ಅಂದ್ರೆ
ಅದೇ ಆಗ್ತಾ ಇಲ್ಲ. ಪೇ ಮಾಡಿಲ್ಲ ಅನ್ಸುತ್ತೆ, ಇಲ್ಲಿ ಲೈವ್ ಸುದ್ದಿನೇ ಬರ್ತಾ ಇಲ್ಲ, ಒಬ್ಬರದು ವಾಯ್ಸ್ ಕೇಳಿಸ್ತಾ ಇಲ್ಲ, ನನ್ನ ವಾಯ್ಸ್ ಬರ್ತಾ ಇಲ್ಲ. ಇವಾಗ ಇದೆಲ್ಲ ನೋಡ್ಕೊಂಡಂಗೆ ಮನೆಗೆ ಹೋಯ್ತಾ ಇರೋದು. ಹೌದಾ, ಬಿಟ್ಟಿದ್ದೀರಾ? ನಮ್ಗೆ ನಿಜ ಇಲ್ಲ, ಏನು ಗೊತ್ತಿಲ್ಲ, ಆದ್ರೆ ಬೆಳಿಗ್ಗೆ ಓಡಾಡ್ತಾವಲ್ಲ ತುಂಬಾ ಗ್ರೇಟ್. ಬೆಟರ್ ನಾನು 2 3 ಓಡಾಡಿ
ನಾನು ಹಂಗೇನಿದ್ದೀನಿ ಗೊತ್ತಿಲ್ಲ, ಗೊತ್ತಿರೋದು ಅಷ್ಟೇ. ನಾನು ನೋಡ್ತೀನಿ
ಅಲ್ಲ ಅವನು ನನ್ಗೆ ಅದೇ ಫ್ರೀ ಆಗೋದು, ಒಬ್ಬನೇ ಅಡ್ಮಿಟ್
ಎಲ್ಲ ಕಂಟ್ರೋಲ್,
ಎಲ್ಲರೂ ಅದಿಂದ ಓದಿ ನನ್ನ ಇಲ್ಲಿ ಪೋಸ್ಟ್ ಮಾಡಕ್ ಹೇಳಿದ್ರೆ ಪೋಸ್ಟ್ ಮಾಡಿ ಬಿಟ್ಬಿಡ್ತಾರೆ.
ಲಿಂಕ್ ಕಳಿಸ್ತಾ
ಅಷ್ಟೇ. ಅಲ್ಲಿ ಹೆಂಗಿದೆ, ನಾನು ಅಡ್ಮಿಟ್ ಲಿಂಕೇ ಕೊಡ್ತೀನಿ, ನೀನು ನನಗೆ ಜಾಯ್ನ್ ಆಗು, ಇನ್ನು ಅವ್ರು ನೋಡ್ತಾನೆ.
ಅವಾಗ ಏನಾಗ್ತದೆ ಗೊತ್ತಾ ಕನೆಕ್ಷನ್ ಇಲ್ಲಿಂದ ಹೋಗಿ
ಅವನಿಂದ ಡಿವೈಡ್ ಆಗ
ಇಲ್ಲಿಂದ ಸಿಗ್ನಲ್ ಚೆನ್ನಾಗಿದೆ ಅವನಿಗೆ ಸಿಗ್ನಲ್ ಡ್ರಾಪ್ ಆಗಿ ಅನ್ಕೊಳ್ಳಿ
ಮುಗೀತು ಕತೆ.
ತಗೊಳಕೊಳ್ಳೋದು ನಾವೇ ಇಲ್ಲಿ ಅವನು ಆರಾಮಾಗಿರ್ತಾನೆ ಸ್ಟೀಮಿಂಗ್ ಕುತ್ಕೊಂಡಿರೋ
ನಾನು ಬೆಳಿಗ್ಗೆಯಿಂದ ತಲೆಗೆ ಹೊಡೆದ್ರು ಈ ಲ್ಯಾಪ್ಟಾಪೇ ವರ್ಕ್ ಆಗ್ತಿಲ್ಲ. ಆಮೇಲೆ ಇದಾಗ್ತದೆ ಅದ ಬೆಳಗ್ಗೆ ಅದಕ್ಕೆ ನಾನು ಬಂದಿದ್ದು ಎದು ಮಾಡ್ತೀನಿ ರಿಟರ್ನ್ ಹಾಕಿ ವರ್ಷದ ಎಕ್ಸ್ಪೀರಿಯನ್ಸ್ ಪರವಾಗಿಲ್ಲ 5 ನಿಮಿಷ ಮುನ್ನೋಣ చేస్తా ಅದೇ ಮುಗಿತಾ ಅಷ್ಟೇ ಇನ್ನ ನಾಳೆ
ಗೊತ್ತು ಯಾವ ಕಂಟ್ರಿ ಹೆಂಗೆ ಲ್ಯಾಪ್ಟಾಪ್ ಸರ್ವಿಸ್ ಮಾಡೋದು ಗೊತ್ತಿರ್ತದೆ
ನಮ್ಗೆ ಎಲ್ಲಿ ಇಡ್ಬೇಕು ಅಲ್ಲಿ ಇಡ್ಬೇಕು. ನಾನು ಬಂದಲ್ಲ 2 ಮಾತು ಕರೆಕ್ಟ್ ಆಗಿ ಬೈದೆ ಸೈಲೆಂಟ್ ಆಗಿ ಹೋಗ್ಬಿಟ್ಟ.
ಲ್ಯಾಪ್ಟಾಪ್ ಕೊಡಿ ರೆಡಿ ಮಾಡ್ಬೇಕು ಇಲ್ಲೇ ತೋರಿಸ್ತೀನಿ ನೀನು ಗೊತ್ತಿದೆ ನಾವು
ನಾನು ಅಂತ ಸೀನಲ್ಲಿ ಏನ್ ಮಾಡ್ತೀನಿ ಅಂದ್ರೆ ಕನೆಕ್ಟ್ ಮಾಡಿದ್ನ PPT ಲೋಡ್ ಮಾಡಿದ್ನ ನಿಮ್ PPT ಪ್ಲೇ ಮಾಡ್ಕೊಳ್ಳಿ ಅದು ಸೀದಾ ಸೈಡ್ ಬಂದ್ಬಿಟ್ಟ ಅಷ್ಟೇ.
ನಾನು ಹಂಗೆ ಬಂದಿದ್ದೆ ನಿಮ್ ಹುಡುಗಂದೆ ಶಿಕ್ಷಕ ಕುತ್ಕೊಳಕ್ ಜಾಗ ಇಲ್ಲ ಕ್ಯಾಮ್ರಾ ಸ್ಕೂಲ್ ಇದೆ ಕಡ್ದ್ರೆ ಇಟ್ರೋದು ಕಡ್ದಿಲ್ವಾ
ಅಷ್ಟೇ.
ಕಡ್ದು ನಿಂಗೆ ಗೊತ್ತಾಗಿಲ್ವಾ ನಾನು ಇಲ್ಲೇ ಸುತ್ತಾ ಇರ್ತೀನಿ ನನ್ನ ಹೆಂಗೆ
ಇನ್ನ ಎಷ್ಟು ಜನ ಮಾತಾಡೋರು ಇದ್ದಾರೆ? ಮುಗೀತಾ? ಮತ್ತೆ ಅವ್ರು ಮಾತಾಡೋರ್ಗೆಲ್ಲ ನೀರ್ ಕೊಡ್ಬೇಕಂತ ನೀರ್ ಕೊಟ್ಟೋಗಿದ್ದಾರೆ.
They're asking us also, they're asking picking up their workshop also they're asking us.